Okay, thank you guys so much for your patience. We will get back on track as far as our timing goes, but I'm Jennifer Norris-Hale. I'm the founder and director of Mission Motherhood, and I just really appreciate everybody who's here today, who might be streaming in. We have a really wonderful event for you guys today, a conversation that really doesn't happen often, and we hope to expand and elevate in our community and around the state, especially for women who might feel like they don't have a voice or an advocate in our community. So that's why we're here. We have some great panelists for you today, or presenters and panelists. We've been working through a few technical issues, but I think we're good. We got those all straightened out. But I would absolutely love to start this off with Eden Beasy. She is the director of Maternal and Child Health Division at Indiana State Department of Health. Actually, she's the assistant commissioner of the Indiana Department of Health. So a new position for her. We're actually very honored to have her. She oversees policies and programs aimed at improving the health of mothers, babies, and families. With experience in public health since 2011, Eden manages multiple programs, including genomics and newborn screening, Title V funding, Title V funded maternal programs, and leverages her expertise in policy development to shape Indiana's healthcare services. So it's an absolute honor to have her provide opening remarks.
Good morning. It's so nice to be here. The honor honestly is mine, and when Jennifer reached out, I was, first of all, yes, it could be about baby giraffes, and I would be here to talk about this today. But really, I was so impressed that the topic today is really about maternal substance use disorder and recovery in community. And y'all are not alone in thinking about this issue in Fort Wayne. We've been thinking about this issue, of course, across the state of Indiana. So I will help us catch up with time. I don't have a whole lot to say other than I'm just really grateful to be here and to share a little bit about what I know about this issue in Indiana. So I have no slides, just vibes today, and I'll read through just a few opening remarks. As Jennifer said, my name is Eden Beasy. I'm an assistant commissioner at the Indiana Department of Health, and what that means is I have the honor and privilege of working at the leadership level at the Department of Health. And what I have learned very quickly in this position is that substance use disorder and behavioral health is a multifaceted issue across the entire health department, across state government, across sectors. And so it's really important and heartening to see all of you guys here today, because we know it's going to take that sort of level of effort to improve that health and well-being of moms and babies. So maternal health in general has been such a focus of conversation, especially mental health, has been such a focus of conversation, especially in maternal health. And while not mutually exclusive, I so appreciate being intentionally focused on the impact of substance use disorder on the health and well-being of moms, babies, and families. Thank you for being brave and lifting up this important issue. Thank you for kind of helping shed the light on this issue that really can stigmatize a lot of families across Indiana. I think what we have done is unintentionally pushed people to the margins over generations, and now it's incumbent upon us to meet people where they are, literally and figuratively, to help them get into recovery and lift them up out of, in their own journey. As Jennifer mentioned and I mentioned, I lead teams that focus on ways that we can make the health and well-being of moms and babies better. So I don't actually know much about the science of substance use disorder or recovery, but I know that our incredible panel and presenters today do have that experience, and they were going to share incredible information with you. What I do know, however, is the significant health and societal impacts that substance use disorder has on Indiana families. So as we think about the most extreme, as we think about the worst case scenario, as we examine our maternal mortality cases, and as a reminder, maternal mortality is the death of a woman during pregnancy or up to a year after delivery, we see that just under a third of cases that we've reviewed over the past 5 years is so overdose is the #1 cause of maternal death in the state. Number one. If we kind of zoom out and we look at the cases in totality, we know that 46% had some substance use disorder had some impact on that cause of death. What a significant thing to focus on and think about in an effort to reduce, and how many moms we could help save in Indiana if we help focus on this topic in our state. FEMUR, or Fetal Infant Mortality Review, those review teams are actually local teams that review on the death of a child death of an infant before their first birthday. Of the deaths that we reviewed in 2022, over a third of mothers were known to have known to use substances during their pregnancy. And we just reviewed a small sample of infant and fetal deaths in the state. I do come with good news, however. Nationally and in Indiana, we have seen overdose deaths overall decrease. This demonstrated reduction is a testament to the hard work of folks just like you across the state and country that they've put into addressing this issue from all angles. Now, I know we can't rest on our laurels, but there's so much work to be done. But what I once thought was this kind of overwhelming, intractable problem, we seem to be, hopefully, chipping away at it. I believe that solutions, however, are best found at the local level. And I learned during my career in public health that those closest to the issue are closest to the solution. That is why fatality review teams, like I mentioned before, like maternal mortality, fetal infant mortality review, and local suicide and overdose fatality review teams are critical tools to review cases and recommended solutions. Each case is examined by community members, professionals, healthcare providers, and more to determine where those points of prevention are. From those discussions, critical and valuable insights and teams are generated with ideas to prevent deaths happening to other families. So show of hands, are folks out here familiar with fatality review teams? Yeah, awesome, okay, cool, great. So we actually have 33 of those suicide, overdose, and fatality review teams covering 34 counties, including right here in Allen County. We have 24 of those fetal infant mortality review teams covering 71 counties. And again, here in Allen County, we have that. So kudos to you guys for really leading the way in examining, determining, and looking at prevention efforts. I love these teams because when problems like substance use disorder and recovery feel like such big, hairy, audacious goals, reviewing where they are for opportunities for prevention at a granular level can make those big, hairy, audacious problems, like reducing overdose, improving access to recovery, feel much more real and feel much more manageable. Because they are, after all, our neighbors. Local solutions are developed and sustained all over the state, just like what's happening here in Allen County. And just to name a few, recovery homes like Volunteers of America and Heart Rock Recovery, keeping families together on a healthy track to recovery. Group prenatal care that are popping up all over the state, and those that are focusing specifically on moms with substance use disorder, create spaces for families that convene with other similar stories. That fellowship of families with similar stories reduces stigma and demonstrates that women are not alone on this journey. In addition, we're thinking deeply and acting on a comprehensive statewide strategy on how to approach reducing the impact of substance use disorder in mothers. And first and foremost, from the state, I cannot go any further without acknowledging my colleague, Elizabeth Wall, who you'll hear from a little bit later today about the Indiana Pregnancy Promise Program. And I want to really kind of lift this up because I think it really exemplifies the effort it takes to get folks into a path of recovery, because it takes systems of people, of organizations across kind of small bits of the state, like people working together, up to state government working together. So I don't want to steal any of your thunder, but I do want to acknowledge that that system is really what is going to turn the tide of getting more families into recovery and systems of care. So within my commission at the Department of Health, which is Women, Children, and Families, and again, I have the privilege of leading teams that are really concerned about lifting up the health and well-being of moms and babies. We've been busy at work launching 2 new AIM bundles. AIM is the Alliance for Innovation in Maternal Health. And those provide practice bundles or playbooks for delivery facilities to implement quality improvement strategies for those really kind of big issues that we see with maternal health. So our 2 latest ones are, and I want to get these names right, substance use disorder and transition to care. And those are kind of rolling out over delivery hospitals across the state. We've received a number of federal grants because we know that this is of importance at the federal level too, to help support maternal health projects, including the Maternal Health Innovation Project, which is currently doing collecting qualitative data, collecting stories of moms either during pregnancy or delivery. And it's been an incredible experience kind of listening to what's rolling in, because these are stories of, in a lot of ways, trauma, mental health, substance use disorder, and talking about it and sharing these data are so important for us to be able to hear and understand stories from individual folks. We do a really good job of collecting a whole bunch of data at the Department of Health and kind of aggregating it and depersonalizing it. And I think it's really important that we lift up and share these stories of individual moms in the state, because again, these are our neighbors. So can we keep it up? Can we continue to reduce the number of fatal overdoses? And specifically, we focus on the issues related to being a mom in Indiana. I think we can. I believe we can do it, but it's going to take the broad system to work together. Healthcare, public health, local not-for-profits, recovery centers, behavioral health, community mental health, and families have to work together. One sector or organization cannot do it alone. You all in this room, these conversations that are going to happen today, this is the work. This is the work that inspires change, that builds relationships, that builds systems, that build movement in communities. I am so incredibly grateful. Thank you, Jennifer, for this opportunity to kick off this important meeting and listen to the incredible experts. I'm so jazzed about the agenda today and the talent and expertise that you all are going to have today. Thank you for everything that you're doing to improve the lives of Hoosier women and families. It really is making a difference. Thank you all very much.
All right, thank you guys, or thank you, Eden. We appreciate you being here, and everyone on our panel who came up through from India, or who may be here from India as well. It was an early morning for you. But yeah, as Eden said, we're doing the work, we're doing it here, and hopefully we'll have the tools as we move forward and past this seminar to, further engage and support women in our community. So our next presenter is Dr. Camila Arnado. She is a perinatal addictionist psychiatrist focusing on mental health and addiction in pregnant and postpartum individuals, emphasizing equity and accessibility. She is the interim vice chair of education at Indiana University School of Medicine and co-medical director at Indiana CHAMP. She leads the Addictions Treatment Recovery Center at IU and is a member of the Indiana Maternal Mortality Review Committee. And just a side note, Dr. Arnado has spoken at Postpartum Support International conference in DC. Whenever I think of an event like this, Dr. Arnado is one of the first people that I think of as an expert in this field, and we're so grateful to have her in our state doing the work as well. So thank you, Dr. Arnado.
Hello, everyone. Can you guys hear me okay? I may have to remove this. Oops. Okay, can everybody hear me? Okay, great. Is it up there? All right, great. And this is the only place we can see it. Okay. I do move around a lot. Normally I have one of those little, but Hopefully you guys can hear me. I grew up in Brazil, not Indiana, the country, and there was a really famous TV host who had a big microphone like this and ran around, and whenever I have to have these, I think of him. Okay, so thank you so much for having me. I, love talking about this topic and working in this area. Super excited about the panelist, Elizabeth, who has already been shouted out. She's going to get lots of shout outs today. We love working with her. We're on the the Maternal Mortality Review Committee together. We actually met this week. So I think, especially on weeks when we've had, review of cases, it's obviously a hard week, but it's a week that really inspires us to get out there and get the word out about the importance of addressing perinatal substance use disorder in pregnancy. I did come up from Indy yesterday, but I'm normally based in Bloomington. So I see patients in an OB office in both. So I'm a psychiatrist, but I'm in OB offices in Bloomington and now also in Indianapolis at the high-risk OB clinic at Riley, which I've really enjoyed getting to see, different populations, different needs, and also work with trainees. So just training and talking about this topic is what I like to do. So I don't have any disclosures other than the fact that I work for 2 very large employers in the state, but I am speaking today on my own behalf, and these views expressed in this presentation are my own and not any of the organizations for which I work or am funded by, although I do appreciate their support. We have some learning objectives. We are going to talk about maternal mortality. We're going to talk about substance use disorder in the perinatal period. And then I'm going to talk to you about a little bit about the mental health provider shortage. And finally, a solution that one of the solutions to that problem. So it's already been mentioned by our wonderful commissioner. That's a very cool title. I would like to be a commissioner of something. Okay. But I assistant commissioner, still it's in the title. I'm vice chair of something, and I would like that to be changed to vice commissioner or assistant commissioner. That's way more cool. So what's not cool is how many deaths we have in Indiana. As you can see here, these are the pregnancy-associated deaths. So that means the death happened during or after the pregnancy, but the pregnancy itself did not, it wasn't necessarily because of the pregnancy that these deaths happened. We have a lot of discussion in our group sometimes to figure out, was it because of the pregnancy or not? It can be hard to tell. We know that being pregnant being pregnant or having been pregnant within the last year significantly increases your risk of dying from an overdose if you are someone who can be pregnant. So as you can see, it's a significantly higher proportion of people dying from overdoses. And then the other deaths just below it, just so you notice, there's homicides, motor vehicle accidents, and then a few ticks down, there's suicide. All of these involve people who have actually been involved with, not all the deaths, but many of the deaths in these other violent instances also involve people who have psychiatric illness or substance use disorder. I don't have it broken down like that in this slide, but unfortunately, mental illness and addictions contribute to a lot of the morbidity and mortality in this population. The other important thing that we're going to talk a little bit about today, and if you've seen my talks, you know that I focus on this quite a bit, is the idea that these deaths are occurring in the postpartum period for the most part. Yes, it occurs while people are pregnant, but they mostly occur in the postpartum period. This is national data. This is just to say that Indiana is not alone. This is not a Hoosier phenomenon. This is a national and probably international. This is actually data on overdoses. So not necessarily fatal overdoses, just any overdoses. And it shows the same pattern. Overdoses go down while people are pregnant, and then they start to go up again in the postpartum period. So why does this happen? Well, for one thing, substance use disorder in the perinatal period is very complicated. If you've seen my talks, you might have seen this journey map. This is from Cincinnati. This was a HRSA-funded project where they worked with survivors and people in recovery and people in active use as well to design a map and to talk about their journey to recovery. In the very middle, right here, they're talking about non-judgmental support. And I think everyone who's at this conference, is interested in supporting perinatal people, and I think hopefully we're all wanting to do it in a non-judgmental way. People in recovery say that that's really important. But the reason I'm bringing it up, this slide in this setting, is to show that there's just so many complications. Life is chaos. So much has happened to people who deal with substance use disorder. Not all pregnant people are women, but the majority are, or identify as women. And substance use disorder is actually gender specific. It's different, presents differently in men versus women. Women tend to start use and progress to illness much more quickly, and they tend to have a greater preponderance of other associated things such as trauma, comorbid psychiatric illnesses. They're more likely to be victims of intimate partner violence. They tend to, the rates in women of substance use disorder in women are rising more rapidly than those in men. And also the other thing is that it's more common for it to occur in the 18 to 29 time range, which is also the time when people are more likely to become pregnant. So just another aspect that's important to see. The other thing that's really important is that for us to remember, because a lot of times in these conferences we tend to focus on opioid use disorder, and that is obviously a focus of my presentation as well. But opioid use disorder in women, and also especially in perinatal women, does not tend to occur in isolation. So people tend to use other substances as well. And that can range from, alcohol, tobacco, cannabis, and stimulants such as methamphetamine or cocaine. And that's really important because it actually increases the risk for mortality. And that's slightly different from men. It is also, polysubstance is also very common in men, but it's a little bit more common in women. So this is some of the basics about substance use disorder in women. Now, what about the fact that these overdoses are happening when they're happening? So the pattern of use changes during pregnancy. As you can see on this slide, the blue line are people who are pregnant, and the red line are people that are not pregnant in the same time period, in the same region. The reason we have these two lines is it's not just that in this region everyone stopped using drugs in this time period. Specifically, people that were pregnant were able to reduce their use of drugs while they were pregnant, then they delivered, and then their use started to increase again. If you work with pregnant people, which I assume you do, or at least you're interested in this population, this probably makes some sense to you, right? You're pregnant, you can feel the baby move. A lot of people will say, particularly with stimulants, I've heard this, they'll say, I could feel my baby move and when I would use. And just seeing that immediate impact was really, meant a lot to me, and I made me really motivated not to use. But it is, even though the person that you're not using for is inside your own body, it's still another person. So, I'm not saying that people who are not using drugs during their pregnancy are not really sober, because obviously they are, but a big part of their motivation is actually external. It's in their body, but it's an external motivator. And you go into recovery very quickly, and maybe don't always go through all the steps that you would have to come to that point if you weren't doing it to prevent your use from affecting another person. So although we're really, glad that people are able to do that, it ends up backfiring, because once that's not inside their body anymore, once the person is not inside their body, some of that sort of white knuckling that they were doing and pressure they were putting on themselves starts to ease and leads to this is part of the reason that they start using again. But the other reason is also perceived stress. So even people who've already had a baby, surprisingly, can trick themselves into thinking that the postpartum period is going to be really a lot of fun, and that they're going to feel very rewarded, and that this baby is going to help sort of continue to motivate them. And I mean, many times the babies do, but they also cause a lot of stress. They do not come out as cute as we want them to all the time. I mean, they're cute, but they're also very squishy and squiggly and much smaller than what you thought they were going to be like. And you have a lot of anxiety about knowing how to take care of them. You know, they're not like they were on the commercial. And somehow people forget this. I mean, not always. Sometimes they have anxiety because they didn't quite forget it. But the level of stress and perceived stress is really high. And if you look at this image, the timing is a little bit different for people who use drugs versus people who don't. It was a small study, so it's hard to know if it's fully significant. But they are having a lot of different stressors. One of those stressors is obviously the 4th trimester, which is that, you know, the time that the baby's still kind of developing outside the body. Ideally, they would stay in the body for, you know, these additional 3 months, but their heads get too big, so they got to come out. And they're not really fully baked. And so those first 3 months that people experience, not only are their hormones changing, that's where I'm talking that you're not really getting the rewarding interactions that you were, you know, hoping for. So it's a hard time. Your sleep is disrupted. If you have a history of trauma, which a majority of our patients do, they can be very triggering. You perhaps didn't have the attachment and mothering experience from your own parents that you would have hoped for, and all of this starts to churn inside you, while at the same time, the urge to start to use can go up. And there's also all kinds of issues related to financial stress, the need to return to work, you know, all the things. At the same time, we look at our sort of perinatal like time course of treatment, like what's occurring in terms of treatment and contact with the medical system, and that's going down. So you're having a lot less visits, and it's kind of expected that the hard part is over, when really it's just beginning. Additionally, in general, OB providers don't have a lot of training in mental health. I think that's changing. We're definitely trying to change that at IU. As psychiatry, we're trying to get into the OB medical school rotation. I'm embedded in a clinic with OB trainees, so really trying to bring them into the fold, and they seem more and more interested because they are seeing these maternal mortality data as well. But it's not their wheelhouse, right? They didn't choose to do psychiatry. They're not focused on this. But I do believe they're getting more interested. And for sure, the addition of midwives, nurse practitioners, et cetera, is helping a lot. You know, they have always, I think, been a little bit more attuned to this area, or felt that this was more part of their role. And so just making sure they have the knowledge is why I'm here today, so they can do all the things. And then also, mental health is one area, but then addictions, you know, making sure that they also feel addictions are part of their role and that they're asking questions about this. Many people discontinue care, and one of the main reasons that they give for discontinuing care is that they don't think that their needs are being addressed. So they're not being asked about mental health stuff as often. They might do the screener, the EPDS or the PHQ-9, but it doesn't always get brought up in their visit. They also want to talk about their relationships. They want to talk about breastfeeding, but they don't want to get like a scared straight or like categorical message. So when we go into our like safe sleep messages, which are very important, and I'm not against them, but because we're very like dogmatic about it, people are not always feeling ready to admit that they're not exactly doing the safe sleep, for example. So if safe sleep is like that, imagine how people are feeling to bring in substance use or to bring up other things that might feel like they're messing up even more. So part of why people discontinue care is they're afraid of the message they're going to get in return if they bring things up. These are some of the other barriers of care. I've kind of already brought some of them. I'm going to highlight racism for a few slides. It should be a whole presentation. I do a whole presentation on it. I'm going to highlight it here because substance use disorder in these populations is even more stigmatized, and people are more likely to face punitive rather than be steered towards treatment. And the rates of things, for example, as being offered medications for opioid use disorder are much lower in this population. Presenting to care is much more likely. There's even bigger fear of being reported to Department of Child Services and things like this. And these fears are not paranoia. I mean, they are real. They are getting referred more often, incarcerated more often, etc. And what this is leading to in Indiana, but also nationally, is a higher rate of maternal mortality and morbidity in these populations. So they're not getting care as early. They're not being offered the same options. There's also epigenetics, so not genetic differences, but epigenetics, which is modifications of the already existing genetic code that we think are related to years and years of stress. So that's another important area that we need to continue to address in our state. So where do we start? This was in the original map where they said non-judgmental support from their providers. I like to put it even more and call it unconditional positive regard. I didn't come up with this. This is from motivational interviewing. And the idea is, in your heart, if you're going to do this work, when you're working with people, you've got to believe that they're doing the best that they can and that they're in good faith to work with you. If you're not feeling that way, go take a break, loosen up, talk to a mentor, and come back in. Because people can, as you can tell, if you're in a setting with someone who doesn't believe in you, so do our patients. I work a lot with this with our trainees because they get very discouraged, right? Like, oh, we told this person yesterday, we saw someone, not addictions, but she has not signed up for therapy, she doesn't take the medicine regularly, and the trainee's like, I'm just frustrated. Like, she's not doing what we tell her. And I'm sitting there thinking, I'm just so glad she's here. Like, she's very depressed and anxious, she has lots of, the medicines we're giving haven't felt very helpful to her. It would be much easier not to try to come to Riley, park in the garage. I'm lost literally every day there. Yesterday I couldn't find the coffee. I ended up having to reverse course and go back to the area where we work because I just couldn't find it. So there's so many barriers to getting there. The person's there, yeah, they didn't follow through with all the recommendations, but how often do we ourselves? I mean, I'm a terrible patient, so maybe that's another reason why I have a little bit more empathy for some of the people I work with. So we need to have unconditional positive regard. There's pretty much nothing that happens if we don't have this, positive, I mean. And the other thing is, we need to have a good diagnosis. We need to be comprehensive, screen for other things. If we're not addressing all the different areas, we don't have much of a chance to really help people. We need to, of course, screen for trauma history, including birth trauma. We need to treat the conditions concurrently. So historically, they would say, no, we're not going to be able to do your addictions treatment until you won't be able to treat your mental illness until you've been sober for 6 months. But then people couldn't stay sober because they were trying to deal with their mental illness. So we've got to address things at the same time. And that doesn't mean throw a whole bunch of medicines at someone at the same time. Sometimes medicines, but sometimes it's therapy or other interventions. Suicidal thoughts and self-injury, we of course want to deal with this because as you saw on the list, suicide attempts and suicide completion is another leading cause of death for moms in Indiana. And having a substance use disorder history increases the risk of those suicides. Okay. Oops. Oh, and then I'm going to talk about this in a few slides, but harm reduction is another really important aspect. Okay, so getting back to one of my other learning objectives, and this will all come together. I'm advising that we do all these sort of treatments concurrent, all this stuff, and you guys are probably thinking, how are we going to do this? We can't even get any of our patients into mental health treatment. It takes months. Our providers don't know what to do. So yes, there's a huge shortage of mental health providers in the United States. Indiana's in even worse shape. When you see all of the counties, including Allen County, are in a shortage area. Marion, and I can't ever remember, I need to remember it's one of the counties in the region, but I don't think it's LaPorte. Which is that one? Do you know? Lake. Okay, so Lake and Marion are not entirely in a shortage. Okay, they're still in a shortage, but there may be like one little neighborhood that is not in a shortage, so then they're in a slightly lighter color. The bottom line is it is very dire. Like, and I'm a very positive person, but our shortage in Indiana is really killing people, the lack of psychiatrists. And psychiatric nurse practitioners too. So this is a big issue. We're going to talk about a solution in a few slides, which is the CHAMP program. But something that the providers that are already here can already be doing is harm reduction. And basically this is do no harm, let patients have shared decision-making, autonomy, informed consent, and prioritize their safety. That's why safety is at the very top. Harm reduction that has nothing to do with addictions would be like using sunscreen, having a speed limit, using bike helmets, or using seat belts. So this is all pretty non-controversial harm reduction, although I don't know if you guys have seen videos of when they first made laws around seatbelt usage. People were pretty pissed about it. They're like, you can't control how I ride in the car. And when I was growing up, there wasn't, as I said, I grew up in Brazil. We didn't even have seatbelts in the back seat. And when I moved to the US, my parents were like, listen, you're gonna have to wear a seatbelt. And I was like, no, but I stand between the two seats. Like, that's not gonna work. So it actually was really controversial at one point, and now we think it makes total sense, and we're always at the Maternal Mortality Review Committee trying to figure out how do we incentivize people to wear their seatbelts, because many of the motor vehicle fatalities, people were not restrained. So harm reduction principle just means that like we want to do any positive change and we don't want to be agents of coercion. When people are coerced to do something, their ambivalence, like their wish to both do and not do that thing, gets totally messed up, and they become even more attached to wanting to use substances, and it really subverts this process. And again, the problem with that, like you may think, but they're not using, isn't it great? It's great, maybe great right then, but it ends up leading to increased risk of mortality after, because when they resume use after not having used for a while, that's when a lot of the deaths occur, because their tolerance has gone down. So here are some examples of harm reduction that might feel a little bit more controversial than seat belts. Probably the ones that feel really controversial are things like safer drug use or, supervised consumption sites at the bottom. A lot of people may be like, oh, I'm okay with a drop-in center, or I'm okay with housing first, or these other things, but some of these other ones here may seem more controversial. All of these have evidence behind them of decreasing mortality. Another thing that is evidence-based for this treatment is medications for medication-assisted treatment, which can include so many things, right? It can include medications for opioid use disorder. It also would include things like nicotine patches, and that's my best example. So here's just a quick slide to remind you what these medications are. Methadone and buprenorphine are approved in pregnancy, and naltrexone is not normally started in pregnancy, but it can be continued if you started it. Just to remind everyone, medications for opioid use disorder is not tantamount to changing one drug for another. The aim here is to help people when they start out, using. Perhaps they are getting into the euphorias and bumping up and down, but by the point that we're trying to give them medication-assisted treatment, they're in this phase right now. And in this phase, what we're trying to do is just help people feel normal. Let their brains kind of readjust to not having those bursts of extra dopamine when they take short-acting opioids, so they can normalize again. Again, the best form of MOUD is the form that the doctor and the patient decide is best for that person. There shouldn't be, law enforcement shouldn't be deciding this, drug companies shouldn't be deciding this. The grandma can come in and help and be supportive, but she should not be deciding. It should be between the patient and the provider. As I've been saying, treatment for substance use disorder is comprehensive and includes therapy, self-help support groups, recovery coaching. In terms of perinatal doulas, I would include all the medical team, including the psychiatrists, and this, in my opinion, should follow harm reduction principles. This is just another image, and to remind you, this is really not an individual sport, this is a team sport. That's why I like being at conferences like PSI. 2 weeks ago, I was at the Black Maternal Health Conference in Atlanta, which was all very, very interdisciplinary. And you come away with so many good ideas when you're with other people. And you don't feel like my trainees. You don't feel so like burnt out and so much like the responsibility is only on you. It's for all of us to figure it out together. So this is, I think, how the providers sometimes feel, both my trainees and the OBs and midwives that I'm trying to help. They feel very isolated, and that's not what we want. This is, when people ask me, what did you learn in residency? This is the thing that I always say, it's never worry alone. And I presented at a different conference, and the guy who went before me quoted the same phrase and then quoted my training. And we were here in Indiana, I trained in Boston, and he said, this is a Tom Gutile quote, and so this is the main thing I learned in psychiatry residency. Never worry alone. Ask a friend, call a colleague, talk to someone when you're feeling like that you're worrying alone. And that's where CHAMP comes in. We have a lovely booth outside, so please come and get some swag from us and talk to Joe. And if you are a prescriber, you can register to receive consultations from us. Otherwise, you can still get our swag and our information and get any provider that you're in contact with to sign up. CHAMP is a no-cost phone consultation line. It runs from 9 a.m. to 5 p.m. Monday through Friday, and we also have an online form, so you could even send us your consult request after hours, although we will answer you only during the hours. We're funded by FSSA, and we're staffed by psychiatrists from Indiana School of Medicine, Department of Psychiatry. We serve any provider in Indiana, regardless of what health system you work in, and you can call about perinatal patients or adult patients, so anyone 18 or over, you can call us, and we will answer your questions. I am co-medical director, and I help the perinatal part because that's my passion, and that's the questions that I want to be helping with, but Dr. Mike Metrick, who's my co-director, is over the line for the adult. We have other consultants, so it's not just the two of us, but we take lots of shifts, so there's a good chance if you call, you might talk to one of us. The CHAMP program has 3 missions. Consultation is the one I just talked about, but we also have an education mission and a resource mission. So today, talking to you guys is part of our education mission, where we're providing information and educating our population. I've already kind of maybe described this a little bit, but you would call our line, 317-274-2400. Our navigators, one of whom is Joe. So if you want to meet a local guy, grew up in Warsaw, Indiana. He's out there in our table, giving out swag and signing people up, and he would be one of the people answering your call. So we're really trying to make this less scary. We're out here, talking to people and showing our friendly faces. He would get your information. He would send a text to me. This afternoon, I think this afternoon I'm staffing the line. I'm back up right now, so probably not needed this early in the day, but we would call you back in 30 to 60 minutes. One of the psychiatrists would listen to your case, and then we fill out a form on a HIPAA compliance service called REDCap, which is a research sort of engine at IU, and send you an email with our recommendations. We'll tell them to you, but we'll also email them to you after with links, et cetera, to any resources that we might have discussed. This is our QR code to register. You can do that right now, or you can also register when you call. We started in March 2023, so up to now we have 417 consultations completed. 1/3 of that is perinatal, a little more than 1/3, but is perinatal, so very proud of that. I think all the talks we do and all the wonderful word of mouth and advertising that everyone does for us for perinatal consultations is really paying off. And we have 462 providers registered. This is the layout of our counties. The blue is where the providers are located, and the yellow is where the patients that they're asking about are located. The reason it's not the same is, people can work in multiple counties, or they can have patients traveling into their county. Allen County is doing really well, you guys. This is my third visit in person to talk about CHAMP, but I've also done 2 virtual presentations to Allen County. And I think that plus really good word of mouth is helping us here. We have 32 calls, which if you compare to Marion and you think about population numbers, that's really, really impressive. So we want to continue stimulating you guys to call. We're just really excited and grateful that providers in your county are using us. This is just another graph. As you can see, we're not getting enough calls. We only got 24 calls in August. And based on the number of people that are registered to be able to call us, based on the amount of mental health concerns that there are, we know there's more calls out there. So again, just convincing people to give us a try. This is what they say when they try. I'm going to read the one on the right, or my right, or whatever the term is, anatomical something. So this is my first experience with CHAMP program, and it was amazing. It makes me feel so much more comfortable treating patients with mental health, knowing I have this resource. And then people, I don't think we have this one on here, but we have a lot of comments that are like, I was so scared to call. I thought it was going to be, that I was going to be feeling stupid with my question. But in general, I'm always really impressed with how much information people have gathered. Because I have half an hour to talk to people, and the people that are calling me sometimes have 5 minutes, 10 minutes. But they have long-term relationships with their patients, so they're able to formulate really good questions. We also provide education, including today. We are launching a new, you guys are the first time that we've talked about this, but this is our new co-medical director open office hours. The first one's going to be October 21st at noon. It's going to be a Zoom, and we're going to do them every month. Dr. Metrick and I are going to be on there. People can call in. They can ask us questions, and we also are probably going to have a few topics prepared that we can talk about, just in case people are feeling shy. But it will be a chance to basically do a CHAMP call with other friends on there so everyone can help each other. And this is similar to the ECHO, which I also participate on. This one is free through IU School of Medicine. Any of you guys can attend. It's 2 Tuesdays a month. It's Zoom. We always need people to present cases. Elizabeth is on there with me too. So you already know 2 friendly faces that are on the ECHO. And if you have a case, we welcome you to come on there and present your case to us. We also do a little didactic, very interdisciplinary. This week we heard about first steps. Sometimes we've heard about the Fresh Start, which I'm sure Brooke will talk about. Wonderful program. We hear about all the different topics. So it's not just medical. So if you're saying oh, but I'm not a doctor or a nurse, doesn't matter. If you work in this population, please come. We talk about peds too on this. We talk about child abuse and developmental stages. So it's very inclusive, and highly recommend everyone to sign on. This is a slide mostly because I hope Jennifer will share this with you guys. These are resources that I use when I have questions. High-risk OB case management is another resource in Indiana. This is part of our 3rd mission, which is resource sharing. This is for non-opioid using patients, but you're going to hear about Elizabeth, so I have to give her the shout out. This beautiful slide that she gave me from Indiana Pregnancy Promise. I'm not going to talk about it because she will, but this is a big, important program that helps to do case management for our patients who have this history and who have Medicaid, and we refer people to this every single day that I work, and we just need to refer more people to them. And then finally, this is a line from PSI, which I'm sure Jennifer's talked about up here. They have their line, and then they also staff the HRSA line, which is a 24/7, 365 line for patients to get connected to resources. Some conclusions, but I think I'm running a little bit, no, I'm exactly on time, right? 9? Oh, I'm perfect. Okay, so just some some of my different conclusions about what's going on. I don't know if we have any time for questions, but I'll be here all day. So if you have a question for me, do we have time now? Oh, there's a panel. Oh yeah, of course. That's going to be so much fun. All right, so we're going to have a panel later, and you can ask me the question then. Thank you so much.
Awesome. So how's everybody feeling? Good. So as Dr. Arnado had mentioned, and Eden had also mentioned, we have a very honored guest today. Unfortunately, Dr. Cooper out of Emory University is unable to make it. Atlanta is completely flooding right now. So she sends her regards, and we will be setting up some type of a virtual chat at some point, so please stay tuned for that. But Elizabeth jumped in yesterday, and we are so honored to have her. As you can see, the Pregnancy Promise Program is a statewide program, and Elizabeth is the program manager, and she's going to provide some more information on that as well. So I'm going to get that set up, but please welcome Elizabeth Wall. See my Gmail, so this is great.
Good morning. All right. Hi, everyone. Thank you so much for having me this morning. My name is Elizabeth Wall, and I'm with the Indiana Family and Social Services Administration with the Office of Medicaid Policy and Planning, and I am here this morning to tell you about our statewide program, the Pregnancy Promise Program. PROMISE is an acronym. Is my sound okay? Okay. PROMISE is actually an acronym for Promoting Recovery from Opioid Use, Maternal, Infant Support, and Engagement. And these are the things that I come up with in the middle of the night when I can't sleep. So I will be giving a quiz at the end of this talk to see who can remember this acronym. So take it in. It's a bit of a mouthful. But I want to say importantly, I do not do this work alone. I'm getting an echo. Sorry, so I'm going to step over here. I do not do this work alone. I have amazing colleagues at FSSA as well as across the state. Just a few of my colleagues up here on the screen. Carrie Michaels is a licensed insurance navigator. Sorry, I'm going to pause one more time. Are you all hearing an echo? No, just me. Okay. So Carrie Michaels is a licensed insurance navigator. And then you see Taryn Morgan as well on the screen, who is a fantastic data scientist at FSSA who helps us with our program and on a day-to-day basis tracking outcomes for our mothers and infants in this program. I am a licensed social worker by background, but we are also guided by Dr. Maria Fennell and Dr. Ty Sullivan at FSSA, who have backgrounds in pediatrics. And importantly, I want to give special credit to Dr. Dan Raciniak, who is the secretary of FSSA, who I really credit bringing this program to Indiana. Dr. Dan is an emergency medicine physician, and he really put the spotlight on maternal mortality due to overdose here in our state, and in 2019 wrote the grant for the funding for Indiana to be able to offer this program. So what is the Indiana Pregnancy Promise Program? So this is a free voluntary program available across the state for pregnant and postpartum mothers who are Medicaid beneficiaries, current or previous opioid and other substance use disorders. So we provide case management and care coordination support for these mothers beginning in pregnancy and extending through 12 months postpartum. And it is very much a multi-generational approach, so that care coordination continues not only for mom, but also for the infant. Our Pregnancy Promise case managers are typically nurses, RNs, or licensed social workers. So we are currently funded by a 5-year federal grant through the Center for Medicaid Services. We are one of actually only 7 states to have received this funding. So New Hampshire, Maine, West Virginia, Indiana, Tennessee, Colorado, and Texas are all of the states that have received this federal funding, federally known as the Maternal Opioid Misuse Initiative. And this graphic just kind of highlights what I just described. So our goals are really to identify mothers as early as possible in their pregnancy. And what our case managers do is help remove barriers and connect mothers to prenatal care, other physical health care, mental health and behavioral health supports. And also we know that moms cannot be successful at getting to all of this care if they don't have a roof over their head, if they don't have transportation, if there's not enough food for the family. So importantly as well, we address the health-related social needs of the families during pregnancy and the postpartum period. So our goals are to get moms connected to care so that they have a healthy labor and delivery, and then we continue that support, ensuring that they continue with their substance use treatment in the postpartum period, that they're getting to that very critical postpartum follow-up care, that we're constantly reassessing for any unmet health-related social needs, and that baby has a pediatric medical home and is getting to those well-child visits, getting those all-important vaccinations. If the baby needs a referral to specialists, our Pregnancy Promise case managers will support the family in ensuring those things happen as well. I just mentioned these goals, but we looked at the data before launching this program in July of 2021, so we're a little over 3 years old now. And we saw, at least in the Medicaid population, that pregnant individuals with substance use disorders on average had less than 5 prenatal care visits in total for the duration of their pregnancy. And even more commonly, pregnant individuals with substance use oftentimes were getting no prenatal care, and we weren't identifying these individuals as in need of support for Medicaid health insurance, for substance use treatment, mental health services, until after the baby was born. So we really felt like we needed to change the trajectory of that, and understood that a lot of the reason why these individuals were not getting prenatal care was out of fear, right? Fear of disclosing, I'm actively using substances, I'm afraid that this will mean DCS is gonna automatically remove my infant. So we've worked very hard to help mothers feel supported in engaging with prenatal care. Obviously, we work with each individual to connect them to local substance use treatment and recovery services. We will meet people wherever they are at on their journey. So we have individuals who enroll in our program who are actively using heroin or fentanyl on a daily basis. across the spectrum to individuals who've been doing very well with medications like buprenorphine or methadone, but with the stress of a new pregnancy, maybe this was a planned pregnancy, maybe it was unexpected, are really looking for some additional support and can also enroll in our program. And as far as their treatment and recovery plan, we see some individuals are ready to kind of go all in with residential treatment, intensive support, whereas other individuals might be very scared or not ready for that kind of formal treatment, but they may be willing to engage in some harm reduction practices, meet with a peer recovery coach. So again, this is really about meeting people wherever they're at on their journey. We also see a lot of other co-occurring physical health conditions where moms may have hepatitis C and are in need of treatment for hepatitis C. And we know, like Dr. Arnato said, so often substance use disorder and mental health conditions are very much co-occurring. And 95% of our enrollees have multiple co-occurring mental health conditions, be it anxiety, number one, followed by depression, PTSD, bipolar disorders. And so getting to all of this care within an individual's local community can feel overwhelming and can be very difficult for someone to manage. And so that's where our team really comes in and helps individuals find providers in their communities, make sure that they have transportation. And our team is willing to reach out to those providers to make sure everybody's on the same page. So, like Eden said, we really are working across systems on a state level and working across programs and local communities to be less siloed in our support for these families. And the other thing that we do, which I think sometimes maybe has the most lasting impact, is to really provide that empathy, compassion, unconditional positive regard for these mothers and families, recognizing that so many of our participants have had a lifetime of trauma and adversity beginning in their own early childhood. And our team really does come alongside these mothers to say, we are with you on this journey, we believe in you, we're gonna take this one day at a time. We know that we can disrupt these generational cycles of substance use and trauma, and we know that with the right supports and resources, you can be the mother that you dream of being. I think the other thing that not a lot of people realize is that our program does not replace any other existing programs, resources, or services. We are truly an additional support. So many of our moms are enrolled in the Pregnancy Promise program. They might also be receiving support from nurse-family partnerships, for example, healthy families. Again, any other treatment or recovery programs they can participate in, and they would never have to choose our program instead of something else. And just a few comments about, so our federal grant funds are very much focused on the opioid epidemic, and that was intentional because we know that opioids are highly addictive, highly potent, and the opioid epidemic has been a little tricky over time, right? And so we really think about these three waves of the opioid epidemic, beginning with initially misuse of prescription pain medications, and then moving into the second wave of a lot of IV heroin use. And now we're seeing sort of that evolution of fentanyl being really prevalent in every community and oftentimes mixed in with other substances. So while an individual may think that they're purchasing a pressed pill like a Xanax or Adderall in their community, they may not fully be aware that that contains fentanyl. So although we know that polysubstance use is very common and many of our participants either have current or history of opioid use, there is also a lot of individuals who are additionally using other substances, cocaine, methamphetamines, alcohol, marijuana. And so we do address substance use broadly, but there is a particular focus on opioids. And I think this might be the third time now you've seen this graph this morning, so again, I don't need to probably hammer this any further, but it is alarming, the impact of opioids on pregnant and postpartum individuals in our state. It is alarming that in the last decade, opioid use disorder among women has skyrocketed across the country. And while all of this is alarming, there is so much hope with this population. We know that individuals are more likely to seek treatment and recovery while they're pregnant. We know that pregnancy changes the brain. It's one of the only times in adulthood where our brains are really, truly malleable, and we can have some positive impact on the adult brain in pregnancy. And we know that there's effective treatment approaches for pregnant and postpartum individuals facing opioid use disorder. And in fact, the American College of Obstetrics and Gynecologists, in a paper in 2017, very explicitly stated that medications to treat opioid use disorder are safe in pregnancy and are the standard of care for treating OUD in pregnancy. Coupled with behavioral health services and other supports, this really can be a treatable condition. However, we know that there is still a lot of stigma across communities, across the general public, across professionals even, around medications to treat opioid use disorder. So a lot of what our team tries to do as well is provide education to other programs and systems. We do a lot of outreach to DCS and to the family case managers within DCS who are oftentimes working with parents with a history of substance use disorder to really talk about the research that supports things like harm reduction and medications to treat opioid use disorder. And just to be very clear about who can participate in our program, an individual can enroll while they're pregnant or up to 90 days postpartum. And that is regardless of the outcome of their pregnancy. So if the pregnancy does not result in a live birth, we can still continue to support that parent through 12 months postpartum, making sure that they are getting necessary health care, making sure that they're continuing with their substance use treatment, getting mental health services. Oftentimes there's grief support when the pregnancy does not result in a live birth. So I want to be clear, individuals can enroll during pregnancy or up to 90 days postpartum, and then support and services extend through 12 months postpartum. And that's true too for some families choose adoption for their infant. They can still be part of our program and receive support through 12 months as well. Or if the infant is placed in out-of-home care through DCS, we'll continue to support that parent and whatever that plan is with DCS through 12 months postpartum. Again, just to be really clear, individuals need to identify as having current or history of opioid use disorders. So we do a verbal screening for our program. So it's a valid verbal screening, and individuals are not required to submit a urine screening or anything like that for enrollment into our program. And then individuals must be eligible for or receiving Medicaid health insurance. And if we get a referral from someone, and oftentimes we do, we'll get referrals through our website from someone who's quite honestly panicked because they've just found out they're pregnant, they know that they're actively using substances, they have no health insurance, and we say, we can help you. As the first step, we're gonna help you through that Medicaid application, and then we're gonna get you connected to all of that care. So it became really important early on as we were developing this program to create a public-facing website with an online referral platform where literally anybody can make a referral to our program. And this is a cell phone friendly website as well. So it's very easy to just go on your phone and to fill out the online referral form. This is a confidential, secured portal. We did all the stuff with IoT and our lawyers to make sure it was protected and locked down. But really, when an individual, whether you're a professional, a provider, or an individual self-referring, or a friend or a family member or loved one making a referral, we just need minimum information. We basically need an individual's first and last name and a way to contact them. We ask for some other information too, and if you have that information and if you know it, that's great. If you don't, you can leave it blank, or you can put in your address and phone number at your clinic or at your program or organization. And you're going to see a button that says click submit, and then you'll get a confirmation that says, thank you, your referral has been successfully submitted. Now we get an immediate alert at the Medicaid office that a referral's been submitted. And in fact, since I've been here this morning, we've had referrals come through, and my colleague Carrie, who you saw on the screen earlier, is handling those referrals now. So we get this immediate referral, we do a check to make sure the individual has Medicaid, and then we get that pregnancy promise case manager assigned over to that individual to begin making contact. So I will say a couple of things. We understand that sometimes providers or family members might be referring someone, and that individual might not be aware that a referral's been made on their behalf. So when we do that initial outreach to the individual, we are very discreet, right? We have to protect private health information, and obviously the fact that somebody might be pregnant or struggling with substance use. So when we're making essentially cold calls to moms across the state, we keep it very high level. Hi, this is Elizabeth calling from Indiana Medicaid. I'd love to tell you about some programs and resources that are available, so that individuals can sort of feel safe to start engaging in conversations with us. And I will say, we've seen primarily self-referrals to our program through this website. Almost 2,000 individuals have self-referred across the state, and it's interesting because the referrals are often coming in at 2 in the morning, 3 in the morning, and again, that's why we felt like we really wanted to have this public-facing website, because individuals aren't always ready for recovery or ready to take that next step to get care between 9 and 5, right? And so, again, this is about equity. This is about ensuring universal access. We also have an email inbox and local and toll-free phone numbers that are also staffed by Indiana 211 outside of our typical business hours. So again, we felt like the stakes are so high with this population that we needed to make it as easy as possible for people to find our program and get connected. And in fact, I just got an email yesterday from an individual who said, she emailed our Pregnancy Promise inbox, and she said, I really want to get enrolled in your program, but I'm really scared about what it'll mean for DCS and how I might be treated. And I can talk a little bit more about how we support moms in that regard. And so just one more time too, so we have 4 partners across the state, which are the Indiana Medicaid Health Plans, Anthem CareSource, MHS, and MDWise. And so our Pregnancy Promise case managers are actually employed with one of these teams. And Indiana Medicaid has always had a structure for offering case management and care coordination support, really across various conditions and diseases that might need some additional support in managing. And so not a lot of people are aware that this is a benefit for Medicaid members. So whether it's a chronic condition like diabetes or hypertension, a Medicaid beneficiary could be connected with a case manager or care coordinator. So when we received the funds for this program, we said, here's a real opportunity to build on that case management structure, particularly for high-risk OB pregnant individuals with substance use disorders. And so our pregnancy promise case managers, because of the federal funding that we received, are able to have much smaller caseloads than they typically would for a Medicaid case manager. So it's one case manager per 35 mother-infant dyads for our program. And we are able to follow them, mother and baby, through 12 months postpartum. The previous structure for high-risk OB case management, the postpartum follow-up period was much shorter, but this grant allowed us to follow mom and baby through 12 months. And so we often get asked, why would somebody want to be part of the program? And we say this is all about connection, coordination, and prevention. Our pregnancy promise case managers, and you saw there, I want to be clear, although our team is housed at 4 different agencies, we really operate as one united statewide pregnancy promise team. So regardless of if an individual has Anthem Medicaid and their pregnancy promise case managers with Anthem or with CareSource, they're going to get the same kind of resources, support, no matter where their pregnancy promise case manager is housed. But our case managers, we've invested in so much training on not only high-risk OB complications and training around SUD and trauma-informed approaches. We've also done so much training around stigma reduction and implicit bias, where we really do, as a team together, kind of have a willingness to be vulnerable and sort of check our own biases, check our own, what are my hang-ups or what are my blind spots around things like substance use in pregnancy, or what perceptions did I maybe have previously in my career about a parent who has a substance use disorder. And so because of all of the professional development and the de-identified case-based discussions that we're having, our team members are just leading with compassion and empathy and so willing to hear each mom's unique story and experience. And they are some of the fiercest advocates for these mothers and will stop at nothing to remove barriers that stand in the way of our moms and babies being healthy and thriving. We've learned so much about local public housing authorities, as an example. Housing is one of our biggest hurdles for moms, right? Safe, permanent housing. We've learned things like some local housing authorities have a lottery system, so it might not be first come, first serve. We've learned some public housing authorities have some biases around individuals who are prescribed methadone. And so, again, this is where our pregnancy promise case managers are willing to pick up the phone, talk to somebody at that local housing authority on behalf of a mom, and say, what can we do? How can we work through these challenges? This mom has an open DCS case. DCS is wanting mom to have housing within the next 90 days so she can be reunited with her infant. Your waiting list is quite long. How do we problem solve this? And our pregnancy promise case managers will take hours out of their day to problem solve issues like this. We've also seen barriers where a mom, she was 8 weeks postpartum, she was in our program, she was in recovery, she was doing really well, she was breastfeeding her baby, and got a call from her parole officer because she had prior convictions. And the parole officer said, oh, by the way, you've got about $2,000 in fees that you need to pay, otherwise you're going to have to go back to county jail. And this mom was so proud of having a healthy baby, being in recovery, breastfeeding, and was so fearful that at 8 weeks she was going to have to leave her baby because she couldn't come up with the funding. Our teams, we have access to some discretionary funds, barrier buster funds. So she called her pregnancy promise case manager and said, I don't know what to do. And the pregnancy promise case manager said, I found a way. We've got funds. Let us help you. We were able to pay those funds. This mom did not have to go back to jail. She was able to continue that bonding relationship with her infant. So I could go on with stories like these all day about the barriers that you wouldn't always think about, that again, our team is so dedicated to, as much as helping a mom make sure she's getting to that prenatal care visit, we know we've also got to make sure that she has somewhere to live, and that she can really focus on bonding with her baby. So, coordination too, like I said, we are very well positioned to get those consents and releases of information in place so that our team can call the OB provider, who is oftentimes different from the MAT prescriber for the medications for opioid use. And also, an individual may be getting behavioral health services or mental health services at another location. So that's already 3 facilities, right? Her OB office, her MAT provider, her behavioral health provider. Maybe she's working with DCS or has a WIC appointment. Again, our team is able to say, let's make sure you know you've got this on Monday, you're here on Tuesday, you're here on Wednesday, let's make sure you've got the transportation. Let's make sure that we're sharing your care plan across your providers so that everybody's on the same page with your birth plan, with your course of treatment. And this takes a lot of effort and coordination, and our team is really excellent at building those relationships so that everybody is on the same page. Dr. Arnado knows too, we see mothers who may be prescribed methadone or buprenorphine, and then maybe other medications to treat mental health disorders. And as the pregnancy goes on, those dosings might need adjustments, or maybe some medication that previously was helping mom is making her not feel well. And oftentimes our moms are scared to voice these kinds of concerns with the doctor because they don't want to be seen as trying to increase a dose, or what's very stigmatizing language as drug seeking. And so that's where, again, our pregnancy promise nurses can step in and say, well, let me get on the phone with you to call your provider and see if we can get you back in and get these dosages adjusted so that you're feeling well and things are working for you. And then at the end of the day, like I said, we really want to prevent the very real, very negative outcomes that can occur for families when substance use is not treated during pregnancy. And we've prevented incarceration, we've prevented DCS from needing to step in and remove the infant. So I don't want to belabor this too much, but again, referral and identification is really important. Because we know these moms are out there and we know that they're scared to get help. So I talked about how our website works, but also our Medicaid health plans are continuously doing data mining. So when they get notification of an individual who's an Anthem Medicaid member, and that they get a notification that says your member is pregnant. They went to an OB appointment, and so we're notifying you as the Medicaid health plan that they're pregnant. We're able to look in that individual's history to see if they do have, in fact, a history of substance use disorder. And if they do, then our nurses and social workers are reaching out and cold calling those moms directly too. So we kind of have a 2-pronged approach to identifying moms. They can either come to us through the website, or we can actually identify them through looking at their Medicaid claims history. And then outreach is so important in our program. As you can imagine, it takes multiple outreaches to the moms to try to engage them in the program, through phone calls, text messages, sending letters, knocking on doors. We will stop at nothing to try to reach these moms. And on average, we found it takes 8 to 9 attempts before we successfully are able to talk to a mom, tell her about the program and how we can be of support. That's really important for any other programs that are case management in nature. I've had a career in this field for about 20 years, and I've worked for other programs where we did 3 attempts, 3 phone calls, and if the family didn't answer, we just kind of assumed they were done and we moved on to the next family. Again, because the stakes are so high with this population, we're talking about life and death, we're talking about 1 day away from a fatal overdose. And because there's so much fear, we have said we are not going to stop outreach. We'll continue to outreach these moms throughout their pregnancy and through 90 days postpartum, up until the very last day that they could enroll in our program. And at first, our team kind of balked and said, that feels excessive. We don't want to, bug people. But week after week, when we have our team meetings, someone will say, oh my gosh, I've been trying to reach this mom for 10 months, and she called me yesterday, and we got her enrolled in the program. So that outreach pays off, and as frustrating as it can feel at times, it's just what it takes, and so it's what we do. So individuals do need to consent to our program. This is a voluntary program. We do share data, de-identified data, with our CMS federal funders. So once we've identified an individual and they've agreed to participate, we do obtain formal consent. And then we do a whole host of comprehensive screenings and assessments initially. So the 5 P's screening for substance use, we do depression and anxiety screenings, we do screenings for health-related social needs, we screen for tobacco use, and then based on those screening results, we develop individualized comprehensive care plans that not only outline the mother's parenting goals, her treatment goals, sort of her birth plan goals, and the idea is that we share this plan, again, with the providers. So once that initial care plan is written, then each mom is going to get that very individualized support from her case manager, which could be, it could be weekly, it could be a couple of times a week, just depending on what her needs are for resources and supports. And it could be by phone, it could be in person, it could be through text message. So we're really pretty flexible in how we connect with families, and we really meet them where they're at. The other huge component of our program is providing family education. So not only are we helping people get to care, but we're also talking about infant-safe sleep practices. We're talking about tobacco cessation interventions. We're talking about infant developmental milestones. We're talking about intimate partner violence. And so as we're making regular contact with families throughout pregnancy and the postpartum period, that education component is so important. Particularly too, we talk about family planning, we talk about healthy birth spacing for our moms, and because we know that the program is going to come to an end at 12 months postpartum, we're actively thinking about that program transition with our moms throughout the postpartum period, because we never want anybody to experience that service cliff, right? While they're in our program, they feel very supported, they feel very connected, and then what's going to happen at 12 months or at my baby's first birthday? And we really ensure that we're doing warm handoffs and that families are connected up with other resources, supports, and programs after our program. All right, and again, you're welcome to have these slides. One other thing that we've been able to do, which is pretty innovative, is our moms have special access to the state CCDF child care funds. So typically a family would need to have an income need and then need to be in school or working full-time to access the child care funds for their children. We worked with our State Office of Early Childhood and said, our moms have so much that they're managing with their daily SUD treatment, they're going to parenting classes, they're going to behavioral health services, group therapy, individual therapy. It's impossible almost to juggle all of that, plus working full-time. And a lot of our moms don't have a safe child care provider within their family or circle of friends. And so our office agreed to say, we will waive that work requirement for your mothers, and so long as they're in your program and engaging in all these services, their children can get this child care benefit, which has been huge. I know I'm getting close to time. I could talk about this all day, but just to give you a quick overview of our enrollment to date, we've been at this for 3 years now, and just this month we crossed a really amazing milestone of serving over 1,000 moms across our state. Yeah, thank you. And I remember Jennifer has been so supportive of our program since day one, and even 3 years ago, emailing to say, oh my gosh, we've served 25 moms to date. We've served 50 moms to date. And then Jennifer would share with her networks in Allen County, and now here we are having served over 1,000 moms across the state. And we've had almost 800 infants born to date, and we have many moms currently enrolled who are still pregnant. We've received referrals across all 92 counties, and we have enrollees in 90 of our 92 counties. And we have helped connect over 400, I think it's closer to 500 now, moms who maybe they didn't qualify for our program because they didn't have a substance use disorder, for example, but we've connected them to other OB case management and care coordination programs. This is really exciting. We're getting ready to publish our 3rd annual report. And what we are seeing as far as outcomes for our mothers and infants is just incredible. We are seeing so many of our infants being born full term, healthy birth weights, not needing these incredibly lengthy NICU stays due to severe neonatal abstinence syndrome. 92% of our and infants are being discharged home together without DCS needing to step in and remove that infant due to concerns about safety and parental substance use. And again, that's because we're working with moms, working so hard to get ahead of all of those safety concerns during the pregnancy. And we're equipping moms with their care plans to take to the hospital for labor and delivery, so that if the cord does test positive for methadone or buprenorphine, moms can say, hey, hospital, you're welcome to call my pregnancy promise case manager. DCS can talk to my case manager. My case manager will tell you about all the treatment I received during the prenatal period, all of the mental health services. They can tell you I'm working on housing, I've got childcare lined up. And so that's really how we've been able to get these really great outcomes and keep moms and babies together. You can see too, 93 to 94% of our moms have no reported relapse or return to use through 12 months postpartum, which is pretty incredible. And for those moms that do, we understand that that's part of the disease, right? And we've actually had moms who have had a really bad weekend and went to their old neighborhood to purchase something, and they called their pregnancy promise case manager and said, I don't want to use, I don't know what to do, I couldn't think of who to call, I'm calling you. And the case manager said, thank you for calling, let's get you back in treatment. So if our moms do have a relapse or return to use, they're not kicked out of our program. We're going to work that much harder to re-engage them in care. And then, importantly, we're here because we want to save lives. And we look at that survival rate of our participants through 12 months postpartum, and this keeps us going every day because not every day is easy, and we're not perfect every day. But when we take a step back and see what our survival rates are for our moms in this program, we think that we're doing something meaningful. And I'm really excited to say that we were just awarded a new grant through SAMHSA, so we're going to continue our program for another several years. We are going to remove that stipulation around opioid use so that any substance use disorder whatsoever, we can make them eligible a lot more easily. We've had those few occasions where a mom has said, alcohol is the only substance I've ever used. In that case, we can't enroll them in our program today. We refer them to other resources, but with this new grant, we'll be able to do that. We'll be able to strengthen some partnerships with amazing programs like VOA Fresh Start Recovery Program, Centerstone. We're going to be able to offer some new trauma-informed parenting support groups for pregnant and postpartum individuals with substance use. So we are just really excited about what the future holds. And then lastly, and I'm so sorry, Jennifer, I'm over time, we just hear stories every day from moms saying, if you would have told me 14 months ago when I first found out I was pregnant and I was just in the depths of my addiction, that I would have a healthy infant, that I'd be in recovery, that I'd have my own apartment, that I would be working on job training, I never would have thought this was possible for me. But with the encouragement and the care that I received from my pregnancy promise case manager, here I am today. And so it's an honor and it's a privilege to do this work and to tell you about it. And if this talk knocked your socks off and you want to hear this again with the rest of your team or the rest of your agency or program, I do have a table, and you can sign up for a virtual presentation so that we can talk more specifically about how to collaborate with your program or your organization. I would love to do that. So thank you.
So I wanted to ask this before. Who has heard of the Pregnancy Promise program since becoming? So it's about 50%. So we have some new interest. It's great that it's gotten up to this point, like Elizabeth said. Even like 3 years ago, we're like, oh my gosh, this is great. And now all the growth and development that's happening, it's just a testament to the need in our communities, but also to the passion of the individuals who are doing the work as part of the program. So thank you, Elizabeth. So we do have about 10 minutes if you want to take a break, grab some coffee, donuts. We have plenty. Put them in your purse. I don't care. But we'll come back with Brooke and Dana. Thank you. So we are going to go ahead and get started with our next presenters. I'm sorry, I'm just pulling up their bios. I am so honored today to have Brooke Schaefer here. If you attended our Maternal Mental Health Conference in May, she was one of the presenters. And we received wonderful feedback. And in fact, she was highly referred and regarded by the director of the Maternal Mortality Review Committee, as well as some other state level organizations as an expert in this field in serving mothers with substance use disorder. So we're absolutely honored to have Brooke with us. And we are also so honored to have Dana Cahill. She is a peer recovery specialist. A few people may have heard her speak before, but when I was speaking to Brooke about this conference, it was kind of an obvious mention to bring Dana in for her passion and support and advocacy for women in the community in recovery. So thank you, Brooke and Dana. I've spoken long enough, and you guys have the floor.
Great. All right. It's working. That's a good start. Is yours working?
Can you hear me?
Yep. Yeah. Okay. Good deal. So, guys, we're going to do a quick introduction and talk about ground rules as well. One thing with ground rules is that our slide deck is not the most important thing that's going to happen today. So sometimes I'll see people who are presenting who will be like, I got 5 minutes, and man, they're going to get through that slide deck, like, come all. I don't care if we get through the slides. I'll send the slides if you're interested in reading the slides. The slides are not the important thing that we're going to talk about. A lot of what we're going to talk about today is things that have gone well for patients, things that have not gone well, those opportunities for improvement. So please interrupt. I know we're going to have a panel coming up, but definitely if something is really on your heart that you need to ask now, jump in and be ready for a tangent. If the slide says one thing, but our conversation is going in another, then we'll go in the direction of the conversation. So let's start with introductions. Miss Dana, why don't you go ahead and talk about your current role and what you're doing right now?
I am Dana Cahill. I am the current peer recovery specialist with the Choice Program at Community East in Anderson. I meet with our women when they come in for detox on the unit, and we discuss where they want to go after, if they have a safe place to go, if they want to go to treatment, what their plans are, and then we see them outpatient in the office for medication and OB care, and I'll meet with them too to see what things they need for baby, if someone needs a driver's license to get a job, then I can take them to get that done, or help them apply for jobs, or take them to the food stamp office, whatever they need. And so I get to build a really cool relationships with the people that I work with.
And I'm Brooke Schaefer. I am a family nurse practitioner, also certified as an addictions nurse practitioner. I am the senior, this is my first time to introduce myself in my new role, so I better say it right. I wish I was the senior commissioner. That was cool to be able to add commissioner. No, I'm the senior vice president for integrated services with Volunteers of America. I said it right. And this is a new role for me. I've been in this role for 2 weeks. Dana and I have worked together for a very long time because I was the former director for the Choice Program with Community Hospital. The Choice Program goes on and will continue to thrive and strive, and I will be with Volunteers of America. Volunteers of America has many programs that we do. Our main focus is on populations that others have declined to care for. So one of the things that we do is work with homeless veterans. We work with people who are re-entering our beautiful world after incarceration. But the place that I'm going to be primarily focused on for a while is going to be Fresh Start. Has anybody heard of Fresh Start programs? So Fresh Start is a residential recovery that women can go to, and they may take up to 2 children with them. So if a woman gives birth and that's the moment that she finds recovery, then she and that baby can be released by court order to Fresh Start. Meaning that if that mother chooses to walk out of Fresh Start, she can, but she cannot take the infant with her. So the infant is very protected in this, but also the mother is so protected in this. How likely do you think it is that a woman will find recovery if her child is immediately, her newborn baby is ripped from her arms? It's not very likely, right? And Dana and I, when we worked at Choice together, this is not me blaming DCS for this, but sometimes their case managers do not know that Fresh Start is even an option. And Dana and I have both had experiences in my previous and her current work with Choice where we are standing in the door of the mother's room after she is 2 days postpartum, literally saying, stop, look at me, listen to me. You do not have to take this baby. You can send them to Fresh Start. And the case manager says, what is Fresh Start? And I say, I used to have different reactions to that. Sometimes I struggled to control my passion, okay? So there were times in my life where I would look at that like, you should know this. Why don't you know this? And then I decided for my own karma, sanity, and beautiful spiritness to try harder to think, what a great opportunity for me to now educate you about what Fresh Start is. So I was advocating for Fresh Start before I even worked for Fresh Start. And we would, oftentimes when we tell the case managers in Choice what Fresh Start is, they would say, oh, that's a great idea. And then the baby and mother would go to Fresh Start and have a very different moment going forward than they would have if they had been ripped apart from each other. So, with that said, I'm obviously pretty excited about my new job because I already got on a tangent talking about it. But, whoops, let's go this way. So agenda today is for us to have a really good conversation about recovery and what it looks like in the real world, the real lived experience is of mothers with substance use disorders. We're going to talk a little bit now about when things don't go right. So Dana specifically, can you talk a little bit about your experiences prior to becoming a peer recovery coach?
Like my experience with,
Kind of how you got first to struggling with substances yourself. Maybe that's a starting point.
okay. All right, so I got pregnant really young. I was 16, I had him when I was 17. My parents didn't really, I never got to the part of thinking like, do I want to keep him or not? I just couldn't get past the part of telling my parents. So once I did, they just both told me I was keeping the baby. So instantly my life changed. I had to grow up. I never used a drug until my late 20s. I got an injury at work. I broke my tailbone and I was prescribed pain medication. While I'm taking it, the doctor never said like how I would become physically dependent on it when I stopped taking it. And so I would go to my appointment. He would give me more. He would write my prescription and tell me we might need to start weaning off of these, but he never would. We never had a plan to do that. He would just write them for me and take my $100 copay. I used pills for probably maybe the first 10 years of my addiction. I always would say, well, at least I'm not using heroin, you know, and I just thought like I'm not a real addict because I don't use heroin. That was my picture of what addict looked like. And so then it got to the point where you couldn't find him anymore. And so I was offered heroin, and of course when you're feeling awful, you'll take anything to try to get that to go away. Throughout this time, I managed to keep a job, take care of my son. Nobody knew that I even had a problem. I was really good at hiding it. And then it just slowly started, you know, everything just started falling apart in my life. So that's when I decided I needed to get help.
Okay. And, you know, you said that you're really good at hiding it for how long? You said 10 years? Mm-hmm. I mean, and that's really, people think that this is like, people who do not experience this firsthand will think that like people just wake up one day and they're like shooting up heroin. And that is not a story I've heard. I'm not saying that there's nobody who has that story because we are all beautifully unique. But it's very rare that you hear people who are like, yeah, when I was 18 years old, I just one day woke up and said, screw it, and went forth. It's usually, there's a tale that starts with somewhere. We'll find with our patients the patients that we used to mutually share. I'll hear stories about the first time I got when I had my wisdom teeth taken out. It was the first time I ever had an opiate. And the very first time I took an opiate for pain control after getting my wisdom teeth, this is exact quote one of my clients said. She said, "It's the first time I ever saw in color." And I had to think about that for a really long time, because does anybody in here have really vivid dreams at night? Like dreams in color, like really real dreams? Okay. I do too, right? And I thought about like, I dream in such bright color. I see every day in such bright color. I knew exactly what she meant. And I'm not asking for a raising of hands here, but if you think about a time in your life when you were maybe struggling with some depression and the world literally just seems grayer, the colors just seem less vibrant. That's to me what she was saying when she said what her first experience with opiates was like. It was like one of those days you're just, everything is coming together and you can just, woohoo. That's how she felt the first time she took an opiate. And the use of opiates has different reactions for different people. Some people take an opiate and it makes them extremely sleepy, and some people like that. Some people take opiates and it makes them extremely high energy. They have a different reaction than most people. And some people like that too. So I'll hear people say like, well, why would anybody want to just be totally numb? Because their emotions are so big that numbness is the only option sometimes. And so there's so much trauma, there's so many things in these people's heads that opiates really help get those calm. And then for other people, it's that prospect of, okay, now I'm going to be able to do all the things that I don't have the energy to do. So there's different reasons why these opiate use disorders happen, but there's also a part of it where patients will get to a certain point where they're not like partying on this. They're not like taking this opiate and like out all night having this awesome time. Like these opiates become a maintenance issue at a certain point. When people have been taking opiates for long periods of time, it's often about maintenance. And that's when you'll see people who are combining different things. So I'll have clients that are like, yeah, I have to take fentanyl every day in order to not be horrifically ill with an entire year of rebound depression before my brain rewires itself. And then I also take meth to counteract the opiates' sedation effect so I can get through my day. And my husband's an engineer, and his response would be like, well, then why don't they just not use drugs? Because it sounds like they're trying to just like feel normal. And I'm like, you're so cute. Like, go back to engineering, you know? And he's a great guy. He really listens, but he always is like, wait, but why? And I'm like, because it's so much more complicated than that. Substance use disorder is so much more complicated than just stop using drugs. There's so many facets that go into this. So, as we're talking about those, Dana, the next thing I was going to bring up is this concept of when we're back to I want to stay with a little bit on those things gone wrong, actually. I forgot the most important part of this. As you were going along, can you speak to how your second son became part of your life?
Okay. I always have a hard time of how to start this, so bear with me. I had been friends. I'm in a very dark place in my life, and somehow I end up hanging out with a friend of mine. We had been friends for about 10 years now. At that time, his name's Charlie. He also used at the time, and we fell in love, or I don't know. We were pretty low. I don't know really what that was, but it was. We became dependent on each other. We did everything together, and so it just felt right he hadn't had any children, so I think by this time I'm in my mid-30s, and so we're like, we had always said before, like, if we should have a baby together. These are the conversations we have when we're not in our right mind. And so we decided, things were working out. We decided that if we're gonna have a baby, we need to do it soon. And so I thought if I got pregnant, then I'll stop using. And it sounds silly. Someone in their right mind would think, let's get sober first and then try to get pregnant. But in my mind at the time, I thought, I will never use when I'm pregnant. That's where I draw the line, and people that do that are awful people. And who could do that? Who could do that when they're pregnant? But it wasn't that easy, so I was so nervous about going in and talking to my doctor about my having this problem. So I think I was about 3 months pregnant when I finally had the guts to go talk to an OBGYN. And when we're talking about it, I tell him I'm addicted to heroin. I need help. I don't know what to do. I had already looked online, and I was trying to find places where pregnant women can go, or and I don't know. So I couldn't find any place, so I thought maybe he could help me. And so he's like, if you're ready today, you have to go directly to labor and delivery, and we'll do a detox on labor and delivery. I went through that detox and was discharged home to the same place where I was living, where I didn't, everyone in the house is using. No one told me. I didn't know you couldn't be around those same people. I didn't know that you have to change the way you drive home, because you can't take those roads, because if you do, it's real easy to just, stop along the way. I didn't know that you had to change everything, drop all the friends that you have. They just kind of sent me off, like, good luck. And I don't remember if it was the first night or the second night, but it was right when I got home. I was jealous of the people that were using. I know it sounds silly, but I was just like, especially Charlie, I was like, why do you get to use and I don't? And saying it out loud now, you sound like you're a weak person, Sorry. So it took me a little longer, like maybe about 2 months, I think, till I finally got the courage to go back for the second time. And I'm honest with him again. I tell him, I didn't work out. Could I try again? And I had come to the realization by myself that I needed to leave. And so I had a plan to go to my mom's and just to get away from him. But the doctor was like, it didn't work out for you the first time, so what makes you think it will this time? And then he said, I don't think you're a good fit for this program. And by then I didn't want to have to go explain it to somebody else again. Because the feeling of judgment is that's what scares you from going in the first place. And so I didn't go back for OB care at all until I went to labor. The first part of my labor story, everyone is really nice to me. Anything you need, I can get it, that type of thing. And then when I got there, like, reality started kicking in. I kept saying, like, I got 3 weeks until I'm going to quit using this day. And, this way I'll get to take my baby home. And I ended up going on which that wouldn't have worked out either, but I just kind of went into survivor mode, like, I'm going to do whatever I can to take care of my baby or get my baby to go home with me. And so I called Charlie's mom, and I asked her if she could bring in some of her grandson's urine so that I could, because I knew they were going to drug test me. And sorry. And then I noticed that they put a little thing over his penis to, like, catch the urine. So I call her again, and I was like, I don't know I couldn't get past what I was going to do when I left there. I just was trying to do anything I can to keep him with me. But the bottle that she used, thank God, it had to have been God, had opiates in it. She was prescribed oxycodone, and so she put it in the bottle and it had the residue in there, so he tested positive for opiates. And then the second that happened, like, the staff changed just like that. They wouldn't leave me alone with him. They watched everything I did. They watched me feed him, everything. So I know that they're telling me that DCS, they're getting ready to call DCS. And so, do you have anybody that that he could go with? And I call my dad because I have two sisters, and my middle sister would have been, she's just, is the mother of our family. She, you know, is always, I don't know, she's always like, why did you do this? You should, you know what I mean? It's never, and I just wasn't wanting to hear that right then. And I knew my dad. My dad was in his late 60s at the time, so I knew he couldn't do it, but I knew he would say yes. But then I started thinking about it, and I was like, I ended up asking my sister anyways, because I knew that would be the best place for him to go. So they take my son away, and I'm getting ready to leave. I have everything packed up, and one of the nurse comes in and tells me that I'm gonna have to wait because security needs to talk to me. So I'm looking at Charlie like, what did you do? Like, what did you do? You know, I'm thinking we're gonna get arrested for having drugs on us or something. I didn't know what was gonna happen. And when they walked in, he's like, I didn't do anything. And so when they came in, they were like, we're here for you. So I had a traffic violation that I think it was like $100 and some, I don't know, but I had paid on it, and I owed $37. And they took it out of my tax check, but it hadn't been updated in the system yet. So I had a warrant out for my arrest. I didn't even know it. So they arrested me for this $37 warrant. And this is where I stopped feeling like a human being. Like I was already feeling like the worst human on the planet. But then I started, the way that they treated me after, it's just like the cops put me in a chair, they shackled me, they handcuffed me, and then they're like, do you want us to put a blanket over us? And I'm like, people are already gonna know I got two cops rolling me out of here, you know? I would have walked with them. I didn't need to be handcuffed. I would have, you know, it just was so embarrassing. And then they shoved me in a room in the basement for I don't know how long it was. I didn't have a watch, you know? So they needed to wait for an officer to be able to transport me to the jail. I was freaking out because I had a DCS case the next day at 12 o'clock. And I was like, I have to be at this court hearing. And keep in mind, I just had a baby. I'm bleeding so bad. I'm withdrawing. I didn't know the rules. It's the first time I've been to jail, so I didn't know, like, you have to, when they put toilet paper out, you need to grab it because people use it as a pillow. It becomes theirs, and if you don't get it, you don't get any. So, like, it's just inhumane how you're treated there. So I ended up missing that court date, and because I wasn't there, I couldn't agree that my sister would take my son. So he ended up going into foster care for about a month until we went back to court, and I was able to get it switched. But all I kept thinking is that these women felt like that it was their job to punish me for what I did. Instead of saying, let's try to help you, maybe we can get you into treatment somewhere, or what, you know, it was just immediately, she's an awful person, let's do what we can to make her pay for this. And so, I don't know. Sorry, I just can't.
Yeah, we'll take a second. How do you? So, there was such a failure on so many levels. And there were so many opportunities where we failed Dana in that. No, I have to say, she wasn't my patient then because I wouldn't have failed her like that. They would have taken that baby over my dead body. So we didn't know each other yet. And I always feel like I have to explain that because I'm so embarrassed for who cared for you. And also one of those moments where I struggle with my professionalism, I just want to throat chop them. Like it just makes, and that, don't take that part out. But there's so much anger in me for that. And when Dana tells her story, you'll see I have a lot of physical reactions to it, but one of my tells is my ears turn red because I'm just so, my blood pressure rises, and all of you, I'm sure, are having a physical reaction to hearing that story because none of you know that. You hear that and no one in this room can think, yep, that was exactly what should have happened. You hear it out loud and you think everything went wrong. What if Dana had had pregnancy promise back then? This was before pregnancy promise. What if somebody had called the champ line about Dana from the beginning? What if Dana had gotten the choice? None of these resources existed at that time. Not yet. They were all sort of coming. And I think Fresh Start was maybe just barely
just
starting.
opened,
Like it
'cause I
had
looked
like a
into it.
handful of beds in Indianapolis only at that time, which is now like approximately 100-bed unit, or 100 beds throughout the state. There were just so many things not in place yet. That first experience was at the first wave of the opiate epidemic when providers at that time in OBGYN were saying things. When a patient would come in, OBGYN would often say, this is not an OBGYN problem, this is a psych problem. So these clients would go to psych, and psych would say, oh, you're pregnant? No, I don't want anything to do with this. And the client, meanwhile, would say, well, what am I supposed to do? They would be hiding their pregnancies from their psych providers. They would be hiding from OBGYN care because they knew as soon as OB found out they were pregnant and had a substance use disorder. There are cases there was a time in Tennessee where they were locking up people for child abuse who were pregnant, who were testing positive for substances. Okay, I've heard people say, yeah, you gotta put them away for child abuse. Okay, how likely do you think it is they're gonna get OB care if they know they're gonna face a felony charge for seeking OB care? It's not very likely, right? And so luckily, Tennessee got rid of that. Thank you, Tennessee, for that. And we'll pick on them a little bit for that. But they did get rid of it because they knew that punitive nature of treating women who are pregnant, who are seeking resources as felons, was certainly not going to help outcomes for these babies. So I want to talk for a minute about the concept of individualized recovery. This is so important, guys, and this is where one of the million ways Dana was failed in the birth of her second son was that she wasn't treated as an individual by the providers she sought care with. They said to her, you get one chance at perfection, and if you are not perfect, you are not worth my time. And I hope that anyone in this room, anyone who would choose to come to a conference like this would surely not have that attitude. But it's absolutely critical that if it takes 52 times of trying treatment to get sober, then we will give you 52 times. As many opportunities as you need to find recovery, because the worst thing that can happen to a baby in their mother's womb is for their mother to die. And so if we need to give that woman 1 million doses of Narcan and 1 million opportunities to come into treatment, then that's how many we should give them. Not everyone loves that idea, but, you know, I got the microphone. So the people need individualized recovery because we are all individuals. We need unique. There are people in this room who are in recovery right now whose journey was completely different than Dana's. Dana and I know a peer recovery coach who her recovery journey was she had one intervention, she went right to treatment, she spent a long time in a recovery residency, she never relapsed again. That's awesome. Good. That is not the usual story. Substance use disorder often has relapses. It waits for clients to. Do you remember Jurassic Park when the velociraptors picked a new place in the fence to attack every day because this is what I call my kids, velociraptors, because they're looking for a new place every day to find a weakness, which is a sign of intelligence, actually, I tell myself when my kids are doing it. But they're looking for weaknesses in my, armor. With substance use, it does the same thing to people. It looks for a weakness. Oh, is the trigger the anniversary of your mom's death? Okay. I'm going to hit that button until you say, I can't take that feeling anymore. I know what would make me feel better. And substance use waits for the weakest moment, the worst day you've had, and it says, I know what would make you feel better. And if you don't have enough training and understanding and support and people to reach out to and a pregnancy promise person to help you and all the resources that exist to say, I feel really triggered today, I am going to call my peer recovery coach and ask her about it. Or I'm going to go do all the things my therapist taught me to do when I feel like this. That relapse is this close. And so that's where individualized recovery has to focus on true individuality. You cannot have an algorithm for recovery. If you have a program that says, if you do this, then you do this, then you do this, your program is wrong. Rethink it. Start over. Because you have to have individual recovery situations. Everyone is different. Nobody gets exactly the same care because no one is exactly the same person. There have to be parameters for fairness. You can't just say, I really like her, so I'm going to give her different rules than everybody else. No. And sometimes when we were in Choice together, we would have to say, okay, this client is difficult. She is constantly angry. But we still need to make sure that bias isn't sneaking into how we care for her. We still have to, get a little, do a little yoga before you walk in the room so you can say, I am here and I am listening with an honest and open face instead of like, what's she going to yell at me, So individualized recovery, absolutely essential. The biggest thing you can bring to these patients is compassion. If you have no idea what to do, you can be nice. And what if those nurses had just been nice to you? Hey, your drug screening was positive for this. What's going on? Nobody said that. You know what they did? They got on mycase.im.gov, I bet you $1 million, and looked up to see if you had any warrants, which was none of their business and had nothing to do with medical care. I wish that that was HIPAA-protected information, because the fact that you can look up someone's criminal record like that and it's none of your business and has nothing to do with what you are doing for them clinically, should be real embarrassed about that. I was a floor nurse. I have seen floor nurses do that out of curiosity. They're like, oh, this client's acting. Let's look up her my case. It's none of your business. It should be actually not. I don't know how you control that, because the legal system does not treat that as protected information, but it's not necessary. Elizabeth was speaking to this earlier, the concept of the Maslow's hierarchy of needs. Has anybody having flashbacks to like Psych 101? Okay. So who's heard of this concept before, the hierarchy of needs? Okay. So you cannot work on your self-esteem if you do not have food and water. So if you have no access to water and you are concerned about how you're going to get water today, you cannot be thinking about, how do I feel as a person? You have to meet your basic needs before you continue up this. And this is exactly what does not get kept in mind a lot in the recovery world, is how do we help people actually meet their needs before we are expecting them to be on time for an appointment? And we've talked about this a lot. Can you speak to that concept, not for you specifically, but for the clients that we used to mutually serve, the concept of like being on time for an appointment in early recovery?
A lot of women, including myself, I had, at the end, I probably hadn't had a job for a couple years. And somewhere along the line, I feel like I forgot how to like do the things that normal people do. Like, I was nervous to make an appointment to the dentist because I was like, my teeth had to be awful. I haven't went so long, and they're gonna look at me and they're gonna, just all of that stuff. So or all the time you didn't have to be anywhere on time. Like, we are spending time to go meet our drug dealer or figuring out how we're gonna get money to pay for our drugs. And so it's like those things don't have, it doesn't come back overnight. You don't just come to one appointment and then you learn life. You don't just come and get to everything on time. I mean, you got to learn time management it was just, I feel like for me, I had to start from the bottom, and just like I was like a new person coming into the workforce because I, didn't have a license, didn't have my birth certificate, lost everything along the way. And so you got to, collect all of those things to get to the next thing, to do the next thing. Seems impossible.
And making it on time with a 10-minute window to a medical appointment. Reasonable or unreasonable expectation?
Unreasonable.
Absolutely. And then in the medical world, we would say to you, you are late. I, the princess of all of the medical community, refuse to see you. And I always challenge other providers. And keep in mind, I was raised by, my father is a surgeon, and they are the ultimate medical provider of like having a narcissist. He's not a narcissist, he's a great man, but they have a very self-centered focus as a provider. They are the king of everything they do. There are entire teams in the hospital that just literally do whatever they say. Yes, doctor, here's your tool. Like, it's a very interesting hierarchy towards surgeons. And he has retired into a gentler heart. He's a nice guy. And when I talked to him about this, he's like, yes, you have to spearhead this, because the attitude of the provider as the queen of everything happening can't happen anymore. What if we just said yes? When the client walks in and they're 10 minutes late, what if we just saw them? Will the whole world burn down? It'll turn out okay. And I get a lot of, man, I know that sometimes provider schedules are literally like back to back to back to back, but I challenge, especially with substance use disorders, if you kind of leave a little space of wiggle for when clients show up 3 hours late, and you just see them, work them in. And what we did at Choice was we had a policy, if you show up and the lights are on, we'll see you. And when we first started doing that, our front desk would be like, she's 20 minutes late.
Is it okay?
Is it okay? I'm like, it's always okay. And by the fourth
still come
time,
ask, I think.
every now and then they're still like, she's 4 hours late. And I'm like, I don't care, because we'll get her in a room. She made it. Think about how much went through that day that she still showed up 4 hours late. That's really optimistic. Right there, we'll take it. That's a start, we'll see her. Because the alternative to not seeing her is that she will not get the medications she can't just walk into CVS and get the prescriptions that we're gonna write her. So if we don't give them to her, she has nowhere to get them. So that means it's a Friday, of course, this always happens on a Friday, that client is gonna go the entire weekend with no medications, with withdrawal, with a lot of potential triggers to use. And that setback, every setback might be the one that kills them. I mean, the fentanyl that's on the street right now, the doses are unbelievable. I mean, when we first started seeing fentanyl, it was one of my clients that had to explain to me. I've learned a lot of things from clients that I didn't know as a person, that hadn't come up in my life. A client taught me about, I thought prison and jail were the same thing. They were just interchangeable terms. Right, you just nodded because you have some experience, right? I mean, professionally or personally, whatever. But I didn't know that. It just never came up in my life. And so, even when I was bad at Purdue, they would just be like, you're being bad, stop it. But I was never arrested. So probably should have been sometimes. But so with that, a client one time said to me, you just use those words wrong. You don't know that they're different, do you? And I'm like, no. And she taught me. Jail is like short term, prison is long term. Okay, I get that. And the clients had to teach me about fentanyl, because I would get clients who would come into our unit to be detoxed and they would test negative for opiates. And they would look at me and say, girl, I just used in the parking lot before I walked in your door. And I'm like, okay, first of all, please discard of your needles properly, thank you. And second of all, why? And one of my patients finally said, oh, I use fentanyl. You can't even get heroin anymore. And I'm like, tell me more. And she said, the fentanyl does not show up on a standard drug screen. And so you could go to the methadone treatment center and get methadone and also be using fentanyl, and the methadone treatment center didn't know because they weren't testing for it. Oh, and she goes, call your lab and ask them to specifically test for fentanyl. Okay, I did exactly what she told me to do. The lab argued with me. She's negative for opiates. Why would we test her for fentanyl? I don't know, let's just see what happens. And the lab finally did it, and she was extraordinarily positive for fentanyl. And I thought, wait, how is this not catching? Because the derivative of fentanyl that's on this, I'm gonna make this really simple. The derivative of fentanyl that's on the street right now doesn't show up in most standard opioid tests. So when you're testing for opiates that a patient is taking, it's gonna come back negative on most point-of-care cups. This is right in the process of changing. We are just starting to get fentanyl on those point-of-care tests.
We have them.
Yeah, some offices already have them. So it should be rolling out soon. But a point-of-care test for fentanyl will tell you. A point-of-care test for opiates will not. So that was a really tricky barrier for us to get past when a patient's looking at you and saying, I just used in the parking lot. I've been using heavily for months. I am physically withdrawing. There's no way it's not opiates. And we were like, but they taught us, we learned, and we got better at it. The fentanyl that's on the street right now is so strong that it is truly, Elizabeth alluded to this some, but it is a single pill can kill situation. The dealers take these pills and they use 3D presses to press the powdered fentanyl and mix-ins into what look exactly like substances that people buy off the street, like Roxy or Norco or Percocets or whatever, even Adderall and Xanax, but they're fentanyl. So we'll have clients come in right now who say, I only use Roxys, I never use heroin. And I'm like, you're negative for Roxy and positive for fentanyl. And they're like, what are you talking about? I only use pills. We're seeing that all the time right now on the clients that we're treating. It's been a long time since I've seen heroin, like just heroin.
Before I got there,
Yeah, it's been a while. How long have you been at Choice?
it'll be 3 years in December.
3 years, yeah. But again, that's something I always tell my kids too. Don't you be taking no recreational pills at any parties, because I'm here to tell you, somebody might offer you what they tell you is an Adderall. Don't take it, because it might have fentanyl in it. But I also make all my kids carry Narcan, so that, and my youngest is 12, and he carries Narcan. So, like, for real, a Narcan. All right, so when we're talking about treatment, and actually we might skip forward one. Okay. I want to talk about when you had your third son.
Okay, so as you can imagine, I mean, after having my son ripped away from me, in the beginning, I did what DCS told me to do. I was at all my visits. I went to IOP. I did my at-home therapy and case management, and I did. But I was doing it while I was still using. So like I was showing up. I wanted to do it, and then I would get to like the last IOP class, and then I wouldn't have a ride, or I would. Somehow I would end up missing it, and so I would have to start all over again. It's just a really dark place in my life. By the grace of God, I got pregnant again. And this time it was like, I'm facing the possibility of losing one child, and then do I parent this child? Because how can I parent this child without that one? So Charlie and I, we keep talking about, like, we're going to do it tomorrow. It's always, we're going to do it tomorrow. Tomorrow comes, we never do it. And I had never done this before, but it was just one day we couldn't find anything. So I had used meth and a lot of other drugs along with heroin. And so we had got crystal meth, and we shot it up, and at that moment, I felt so sick. Like, what am I doing to my baby, you know? And so I looked at Charlie, and I was like, I'm going to my mom's. And I called my dad and asked him to meet me at my mom's. And keep in mind, they all think I'm sober this whole entire time. And I was like, I need help. Somebody help me. So my dad was like, my aunt is a nurse. I'm not sure if she's way bigger than that now, but it's always been, call Aunt Barb, you know, so
She's actually a midwife and the head of all APPs for all of Community Health Network, so she's like a big deal.
She's more than a nurse. It's a solution for everything. So I called her. It was like 7 o'clock on a Sunday, and she was like, let me call my friend Brooke, and let me see what I can do, you know? And so I don't remember if I called you or she had you call me. I don't remember, but I was like, I need help. And she's like, well, when can you come in? And I was like, I have DCS court this day. I have visits with Carter, that's my middle son's name, this day. I have therapy, you know, all of these requirements for DCS. And she was like, or you could die tonight. And I don't think anybody had ever said that to me. I think I never wanted to die, but I think I was at the point where I didn't care if I lived or died. And so we ended up, she said to come to Community East. So my dad picked me up, took me up there. While I'm there, I meet with Brooke, and she's like, what are you going to do when you get out of here? And she told me about Fresh Start, and she said if I want to go today, then, or when I get discharged, she would have a cab waiting for me, so that it would take me straight to Fresh Start. And I hadn't shared all this, but I had been out. I had done several detoxes and and inpatient treatments, and
The struggle of those connection points after you leave detox and what happens next.
yeah. So I'm sorry,
It's a lot.
yeah.
Yeah. So you were in-house at East, and then we had that cab waiting for you.
And so I go to Fresh Start, and right when I get there, they start working with me, because that's what I was going to say. Every time I would go complete these treatments, but then they'd be like, it'd be a day or two before I can go from detox to treatment, and during that time I would always fail. And so when I'd go back, they wouldn't accept me. So we get to Fresh Start, and they start helping me figure out, like, they meet with you the first day, and they start saying, like, what do you need? Do you need a license? Let's get you signed up for food stamps. If you don't have housing, like, you make a plan, and they help you get through that. And at this point, my son, I'm in termination of rights for Carter. I'm 2 weeks away from losing him. And that program was so powerful that they switched it to reunification, and I ended up getting him back. So I have both my children.
Yeah.
Thank you. But if I would have had a place like that with Carter, my youngest is Oliver, I mean, I would have, my life could have been so different, if somebody would have just cared enough to, want to help. It could have been different. But I'm grateful for how things worked out. I wouldn't be where I am today if it, but then after I went through the program, it was a year later, Brooke had offered me a position as a peer for the choice program. So it's nice to be able to work for a program that I've been through, so I can show everybody what a great program it is, and how your life doesn't have to be like that. You can do whatever you want. So
You can find real recovery. And Dana won't brag on herself, but I will. Dana is a certified peer recovery coach. When she joined Choice, she did not have certifications, but we had grant funding for her to work for us as an uncertified peer for a year. So she was getting a livable wage while being certified as a peer. And then that grant funding paid for her to get her certifications, which cost around like $1,500 total in the end. So she was paid for the time she was training. Then the grant paid for her to get her peer certification. And now she's a certified peer recovery coach. She's also a certified community health worker, which she got through a program called Aspen, which also helps people to get certifications that allow them to continue their careers. She also is one of the best parents. She is probably the best mother I have ever seen. And that is really powerful. Those boys are so blessed to have Dana as their mom. And Charlie's sober, and that's a beautiful thing.
yeah, I had to tell him, I'm not gonna do this and get her kids, and you piggyback off all the hard work I did. So he went to, it was the day before I went into labor, he went into treatment, and so, and he's been sober ever since. So he's been sober since June 24th, and he's doing really great. He's somebody who I thought he would never do it. He was content with like visiting our son. Like, he didn't know what it was like to have a child before. So it was like normal to him to go to these visits, and something happened. We still haven't talked about what made him finally go, but I'm just so grateful because he's the best dad too. So
They co-parent in such a beautiful and peaceful way. Their boys know them as a team. And they do a beautiful job of that while both focusing on their own recovery. And that's hard work. And that recovery takes daily maintenance. And they both are devoted to that and the lives they give their sons. So What's the really great news that you have right now? Your housing?
Oh, I was looking into the Habitat for Humanity program because, our moms need housing, and so I was reading what you needed to do to qualify, and I'm like reading them off, and I was like, never owned a home, check. I'm going, and I was like, I can apply for this. So, and what better way to show them how to do it by going through it myself? So, I got accepted in the program. Fox 59 sponsored my panel build, so we just did the panel build last Friday, and it should be done, I think, by the end of April of next year. So I will have my own home here shortly.
Yeah.
Which is something I never thought. I was paying for other people's places. That's no fun. I want something of my own, so.
Yeah. And she and the boys go to the lot and like play, like kickball and stuff on the lot just to get to know their neighborhood and get to know their future side of their house. And you can I'm a big hippie. I really believe in karma and energy and the things we do. And I bet that property is like, I get these two little boys. Like, this is going to be so great. These kids that play sports and this mom that's like going to throw that ball 6,000 times if they want her to. Like, it is just good in every way that life is good. So, good job. So as we're talking about that, when that comes to the recovery journey, we're not just here to make you cry, which if you didn't, man, what's wrong with you? But the thought that our programs, the help we give our clients needs to be based with the word yes. Can you help with this? Yes. I don't know how, but I'm going to figure it out. There are a million times when we were starting Choice that we looked at things and said, I have no idea how we're going to find foster care for the dog. The dog's name was Bullet. We had a client walk in. The dog is not HIPAA protected, so I can use his name. She walks in with Bullet. He's this like little miniature, pinscher or something. He's super cute. He's in her bag, and she's like, here to detox. And I'm like, okay, girl, glad for that. What's this? And she's like, that's Bullet. I'm like, okay, but Bullet can't enter the hospital. And she's like, well, then I'm not coming. It's me and Bullet or not me. And we said, okay, we'll keep Bullet. We'll deal with Bullet. I promise you, on my life, we will keep Bullet safe for you. And she's like, if anything happens to this dog, I'm coming for you. Like, fair. That's a fair trade. Okay. So I'm like, honey, I'm going to bring a temporary dog home. And he's like, oh, no, you're not. So please keep in mind, I live on a farm. I collect a menagerie of creatures for my enjoyment, and he has had enough. Okay, so like he is a good egg, but you can push a man too far. And he's like, you are not bringing some random dog into this house. Okay, fine. There are places that do temporary foster care for dogs. Like, who knew, right? So we find Bullet temporary foster care. He has a jolly old time. And then Bullet and his owner are reunited after she is ready for Bullet. Because she said, my thought was, well, you can just like take him to the pound and like, then you can, I don't know, he just like sits there in suspended animation and you can get him back. Because I've never had to do that. Or I would like bum a friend into doing it, right? But her resources were not in place to do that. So it was survive. In her mind, survival without Bullet was unacceptable. Okay, then Bullet is part of our program. Yay, Bullet, right? And so we figured it out, and she did very well, very, very well. And Bullet was part of that journey. We had another client, same thing with a pet, similar concept, where the boyfriend would tell her, if you leave this house, when you come back, your dog will be dead on the front porch. If you go to your medical appointment, I will kill this dog, and you will see his dead body. And she was terrified to leave her house, and we kept calling her, being like, hey, can you come in? Like, we have an opening. We'll see you as a walk-in. Come anytime. Nope, nope. And didn't want to tell us why. And then finally, we got to the why. And then we were like, okay, this we can help with. She also ended up in a great situation with that dog and her child, so, and not that boyfriend. So that was an excellent situation, but these clients do not walk in the door and trust you immediately. They do not walk in and say, I know I believe in you. Do you know who the first person they always are ready to tell everything to? Her. Because she's a peer recovery coach. And Choice was one of the very first programs in the entire state to bring peer recovery into women's health. You do not see a lot of peer recovery coaches in a women's health program. And there she was, and making a huge impact. And the clients, they'll believe in me soon. They believe in her immediately. So then we could play off each other. It's like, okay, you're getting to know me, and they're like, Brooke seems crazy, but okay. She at least seems like she cares, but she also seems crazy. And then they meet Dana, and they're like, okay, but Dana is totally 100% in from the start, and Dana trusts Brooke, so now I trust Brooke. And that change in rapport, one of the things that we had to do in Choice, because our clients just basically demanded it, was that clients could stay in programming with one program. Instead of like, okay, you're no longer pregnant, now we're going to switch you to a different program. People who have a history of trauma hate transitions to new providers. New faces can be extremely difficult for them, and new offices and a new front office staff and new parking and all these news where they have to tell their whole life story again. You said that. You didn't want to tell another person what was wrong. It had taken so much bravery to tell them and be rejected that you just couldn't stand being rejected for help again. And so if we keep people in programs where they don't have to go on. So now Dana is a big part of helping run Choice, and Choice does not, patients can stay in Choice as long as they want. I mean, there's toddlers, there's moms with kids with toddlers now.
Right now, yeah, we have more people, we call it legacy, and these are women who have already delivered. Then in legacy, then we do pregnant women, so.
Yeah.
And they're just so grateful, because then they lose, my help. They're like, man, what am I gonna do without you, And so now I get to help them forever, and then we get to see like how well they're doing and get to see their kids grow up, so I think it's really cool.
The toddlers come in and just shred the place, and it's so fun.
They pull the fire alarms.
Yeah, they did pull the fire alarm. That's not supposed to be funny, but that was so funny. So, and she's like, ah! We're like, it's okay, we'll figure it out. This is a fire alarm. That's a spirit of yes. I'm not going to fire a client because their toddler pulled the fire alarm. It's a tall toddler. But, you got to go with that. Like, figure it out. Like, I mean, if you have ever been responsible for a toddler, you know that sometimes they are difficult to contain. And so, yeah, the kid pulled the fire alarm. There are places that would have discharged her from their care for that. Come on, loosen up, right? Like, just say it's okay. So, one of our big things in treatment, and this is something that Dana and I will take with us no matter who we work for, is this concept of progress, not perfection. The expectation of a client to be perfect is an unreasonable expectation. You are the problem. The physician who looked Dana in the eyes and said, "You've tried this once, it didn't work," dismissed. "I'm not going to help you anymore." Think how much bravery it took for Dana to say, "I tried this once, it didn't work. I need more help." That's where she should have got more services, not had the easy button services removed from her. I mean, when people are in need of more care, you should never tell them that means you need to go away. You should be isolated because you need more than I have the mood to give you. No, dig deeper, figure it out, find a yes. And that progress, not perfection, you spoke to that with the concept of when people are beginning their journey. When you are 3 days sober, it is unreasonable for me to expect you to be on time. That's not reasonable yet. We'll get there. When you're 3 years sober and you're late, I can say, "Hey, dude, come on. No other doctor's office would let you be late. You've got to figure this out. How can we help you figure out your timing?" I mean, really around 6 months probably.
Yeah. But I can pick them up too. We have a van, so I can pick them up, or we have an Uber account, so I can Uber them. So that's one really good thing for our program, especially with all the appointments that our moms have. At least that's one appointment they don't have to worry about how they're going to get there. And then if there's other ones, if my schedule allows, I can take them too. So
Speak about the rides from detox to recovery. So sometimes Choice will detox a client, just like what happened with Dana, and then they will help that patient find a recovery residency, maybe Fresh Start, that makes sense for them. Talk about that ride, like when you're the one driving the van.
usually it's pretty quiet in the beginning because they are like, "Oh shit, I'm going," you know what I mean? Like I know the feeling that I had every time that I was on my way to treatment or when I got there, like, how did I get here, you know? And so I feel like they have so many things going on, so I just try to share my experience with them, because I do send a lot of people to Fresh Start because it's a program meant for it just fits with our program. And it helped me so much, and I've seen it help so many other women that it's just my heart goes to that program. And so I can say, I've been through this program, look what it done for my DCS case, this way you don't have to be separated from your baby, because, everybody wants to bond with their baby in the beginning, and so I try to turn it into a more positive thing so that, and by the time I feel like, because we have a lily pond too, which Brooke came up with, it's like a comfort closet for.
Dana stocked it. We did this together. She's giving me props, but it was together.
She said, what did you need when you went to treatment? And I didn't have anything. We were living out of our car. So my mom and dad were able to get me some things, but it's a lot when you don't have anything. And so we have toiletries, clothing, shoes, anything you could think of, we have it. And it's all things that we would use too. We don't want to send them with junk stuff that we wouldn't use ourselves. So.
And it was really important to us when we started it that the products we had in the lily pond were not the products used in the jail. And the reason is people have a really strong memory to smell. And so if I give you the same smelling soap that you used in the jail, you will consciously or subconsciously link that to your experience with incarceration. So I want to give you some herbal essence instead, because they don't give you that in the jail. And so we're not talking super bougie, like we're not handing out like Aveda products, right? But we are handing out products that we would use ourselves so that clients cannot be triggered by scent that they smelled in the jail. And it's amazing. One time we got some crappy shoes in the lily pond, and a client was like, "These are jail shoes." Immediately, like I don't
told her not to order.
Yeah, we were like,
so.
"Okay, we're going to donate those and get
We
different
have
shoes."
my coworker Kathy. She likes the bulk items. She wants to get the most she can for her money, and I'm like, those are going to give them splinters.
She will pay $15 in shipping, but man, she's going to find the 99-cent item. Yeah, she's so funny. So yeah, Lily Pond was a huge part of that.
And so it's nice. I get, I drop them off with their new things. I mean, it ends up being a lot. They can't carry it themselves. We have pillows, sheets, everything. And so by the time they get out, they feel a lot more comfortable with going and
Human.
and they're walking in with their own things because it sucks to have to always ask for something.
Yeah.
They have stuff there, which that might be something you can work on.
Okay.
But they're not good products. They're like what Kathy would order.
Did she just give me a dare? I am so in. And
I take them to eat too. I forgot about that. Like
That's
I take
the
them
really
to
big
lunch
thing.
on the way there, so that they, it doesn't feel like you're like dead man walking. Try to mix it up a little bit.
And then Choice has it's a very small amount of funding it takes to do that stop for lunch, but it's a huge difference in rapport building. When you eat with people, you build rapport with them. And so for Dana to say, "Oh, where do you want to stop for lunch? You want to stop for Chick-fil-A?" And they go in and they sit down and they eat Chick-fil-A together, and then they get in the car and keep going on to the residential recovery. That builds huge volumes of rapport, huge. So it's a really big deal. And Dana has that process beautifully refined as a moment when clients can really feel safe and welcomed and treated with humanity.
By the end, I know their whole life.
Yeah, everything. That's for sure. So let's see. We touched on this one a little bit, but I really want to come back to this, that there is a huge call in the medical community amongst nurse practitioners, any providers, but I see it mostly, I see it a lot amongst nurse practitioners. There's a cultural shift that has to happen there of this attitude of, I am the boss and my needs are the primary needs in this office. I will not see late patients. If a patient annoys me, I will put them on someone else's panel. If like this kind of behind the scenes, this is about me, it's not about you. You are here to serve the clients that you care for. And this attitude of we are of service to the clients we are here for is really important to me and important to the programs I develop. And I just can't function in a clinic where we have this very firm rules about things that are not appropriate. There have to be some rules, okay? You cannot be violent in the clinic. There are certain rules of behavior that are essential. I'm not saying it's just a free-for-all, but I'm saying the client-centered care is the most important kind of care that we can provide. And princess status stops. I do love being a princess sometimes, but not in the clinic. So The trust of providers, Dana had spoken to this earlier about the trust that these clients build with the staff who are caring for them. This is critical. You will never get the best outcomes if the clients do not feel they can trust the providers they're working with. And that's what happened with you, right? You didn't get OB care with your second son because you did not have trust in that system and how it was going to work. Yeah. And you will see these clients, I think about, raise a hands, do you think that probably most people with substance use disorders have a history of trauma? Raise your hand if you think the answer is yes. Yeah, the answer is definitely yes. There is no, you have to be so careful with the trauma-informed care that you're providing to clients. And part of that is that trust building. It was worded so well, unconditional, how did Dr. Arnado said it? It was unconditional connection, or I wrote it down actually, but it was this great concept that you're just assuming that your client is trying as hard as they can. And you're assuming that your patient is doing everything they can and that you are there to help them with that. You're giving them the benefit of the doubt right from the start. That is important with every client you have connection with in any way that you have connection with them. Client, patient, I use the terms interchangeably because we're talking about the people we serve. You have anything to add to that? So what do we need now? We've come a long way in Indiana. It's been really big what we've got. We've got Pregnancy Promise, we've got the CHAMP program, we've got Choice, we got Fresh Start, we've got all these programs working so hard, and I think the programs play pretty well together, and there's always room to continue to grow how we work together, but there's a lot coming with that. There's a lot that's happened, but now what do we do? And the one that Dana and I talked about a lot when we were in Choice together was the issue of housing, right?
It's the biggest thing.
Yeah.
Yeah.
Housing is huge. And can you speak to what happened when you left Fresh Start? What was your housing experience straight out of Fresh Start?
Well, I didn't have anywhere to go. My parents were both done with me. They didn't, they'd given me chances and they just didn't want to help anymore. And so I was lucky enough to get a grant through Fresh Start. So they paid for my housing and my rent and my utilities. It ended up being for a year because I got a job. COVID happened and I had a job at my kids' daycare, but we couldn't. They kept pushing back the start date, so they worked with me. I'd meet with them every month. We would sit down and she'd be like, "What are you in this month? What have you been doing?" And I'd tell her the million things that I have to do, because DCS didn't just leave when I left the VOA. So helped me I got a little one-bedroom apartment a couple blocks from the VOA, and I could walk to my services, and I didn't know where I would have gone without that, so
Yeah.
very grateful.
Yeah. And there's great things coming from VOA I'm not trying to be a VOA commercial, but there's a lot of great things coming for VOA with housing. There is so much room for more housing. I'm not sure we could I would love if the problem was we had too much housing. That would be so beautiful to be like, oh my gosh, we're gonna have to rent these elsewhere because they're just sitting empty. Housing is a huge barrier, and we would have clients, so when a client tells me I have this problem, I can't get anyone at your office to answer the phone. So the first thing I do is call the office from a phone that isn't under my name. So take my kid's cell phone and call the office. And then if they immediately answer, I'm like, okay, I'm not having that same problem, so let's figure out the solution. I'm not saying the client's not telling the truth, I'm just saying I think they're answering the phone. So I have another little experiment I'll do where I will call an apartment complex and say, I have $5,000 my mom just gave me. I have a job that's full-time, I've worked there 2 years. I have a felony for an empty syringe from 6 years ago. Would you rent me an apartment? Absolutely not. No one has ever said yes to me when I ask that. And I'm using my big girl vocabulary, and I'm asking questions, and they are saying, you sound like a nice person, but no, you cannot have an apartment, even under that scenario. And that's a pretty good one. That's not usually the scenario. How do people get housing? They can't. And it's this horrible thing. And, Elizabeth spoke to this some too about the concept of sometimes you just need a little relief. Like if you could just get this $2,000 to pay your court fees, you don't have to go back to jail and you could continue to breastfeed your baby. And then this will all continue on a recovery journey instead of in a crash and burn situation. And that's why places like Pregnancy Promise need funding for those things. They've got to have those emergency contingency moments where if your auntie could just give you $1,000, you could keep going forward. Housing is even trickier in that regard, because even in the scenario I was presenting where my mom had given me $5,000, and I'm like, you could have it all as my down payment or my security deposit. Nope. And the one really honest answer I got was, we just don't have to. There's so many people that need funding or need housing. We don't have to do housing for people with a prior felony. A 6-year-old felony for an empty syringe, like, didn't hurt anybody? Like, no. Okay. So that makes things very tricky. We often see clients end up in housing situations that are not ideal because that's all they could get. We had a client struggle with cockroach infestation that was quite horrible for her and her family, and it was very dramatic, and she did everything she could. She went through every resource she could and could not get it fixed.
And then when I moved she finally did get to move houses, and then when I went to drop her some stuff off, and she's like, I'd been talking to her for like 15 minutes, and she's like, oh, by the way, we have bed bugs here. So she moved from one, then I'm itching all over, I'm like,
Yeah.
but she went from one problem to another problem because she was so desperate to get out of there, and then all she could qualify for is this junk apartment over here, so.
That had bed bugs. Yeah. And of course, the landlord wouldn't do anything about it. So we're trying to help her figure that out. And, that's just one more stressor. Life is stressful all the time. That's one more stressor that makes it even more complex. We see this problem where it's, you can't get a job because you don't have daycare, but you can't get daycare because you don't have a job, and then you can't get housing because you don't have daycare, but you can't get a job, and it's just this circle. And anywhere we can come in and the resources we offer to bridge those gaps, to say like, okay, you can have childcare free of charge for 3 months while you find a job.
Oh, they switched that now.
Yeah.
Recently, you can.
Okay.
You could get a certain time period to get a job.
Yay.
Yeah.
And those,
Does
okay,
that make sense?
check.
Yeah.
Then we'll move on to the next
Yeah.
one. You can't get your kids back from DCS because you don't have housing, but you can't get housing because you have to jump through DCS hoops all day,
And
every
you
day.
can't get a job, because you have all of these, I think I had at one time 18 hours worth of visits. And I'm like, how am I supposed to work, do these visits, and do all the other stuff that I'm required to do?
The IOP.
And, yeah, they make it.
The random drug screening.
Yeah,
And
you have
so
to
you're
call
supposed to
every
have a
day.
boss where you can say, hey, I'm going to be 3 hours late because I have to go to do random drug screening today.
Oh, I had one, I worked a 6 to 6 job, and I was required, the place I had to go, and you could only go to the one place, closed at 6 p.m. So I had to risk my job if it came up on a day that I worked to leave early, God bless you, to make sure that I got that, because it's an automatic fail if you don't take it. And so it's like, it's really almost impossible. But it just sunk in, one of my friends said to me, you just have to surrender to DCS. And like, once I was able to understand that, things went a lot easier for me, but it took a long time. It's so overwhelming.
And that was also part of why it's important to have people with lived experience on a treatment team, because sometimes in choice, I would be like, well, why can't we ask them to do this? And Dana would be like, Brooke, DCS is just driving everything you do. If you ask them to do that, you've just added 5 hours to their week when DCS is already taking up 25 hours of their week. So how is it, come on, And Dana was pivotal in saying, when I'm like, they've been in this program 3 months and they need to figure out their own transportation and blah, blah, blah. Dana would be like, chill. Like, we need to give them longer. She's not ready yet. And that was huge, huge. It continues to be one of the driving forces behind Choice continuing to be a very successful program. Patient-focused care, which we've talked about, that the patients need to be part of this, not just the algorithms that are created. A livable wage, I won't go too far on this one, but I'm just saying it's really hard to be a single mom with no other resources. At a certain point, you make too much money for Medicaid, and you lose a bunch of your resources, but you don't make enough money to pay for childcare. There's this major bridge moment between those that we need to keep working to help with. Because if you make $20 an hour, you lose $5,000 worth of resources. So we need to think about that. Forgiveness in our legal system. This one hurts a lot because I'll see people who screwed up. They did their time, they did the thing, and they paid for it, and they paid their debt, and now they cannot get a job. And they cannot get back into anything that will help them with a sustainability plan. That's really hard to watch. And we see that with our clients, where it's extremely difficult for them with mistakes that they've made, that they have made huge progress with. There are some great resources in place. There are some phenomenal problem-solving courts that help get these things removed from people's records. There's a lot of resources happening with this, but it's something we have to keep working towards. This is a list of books that I love. I always bring them up anytime I speak. These are books that relate to different parts of substance use disorders, different aspects of care. I think that if you were gonna just pick two, I never thought I'd read a book by Nikki Sixx. I'm the perfect age. I'm 47, so Motley Crue is part of my heritage. I was in the era of big bangs, I had really big bangs. And so Motley Crue, yes, love Motley Crue. Did not think I would read a Nikki Sixx book at age 40, but here we are. That book is phenomenally well written. It's a compilation of his diary entries from when he was actively struggling with heroin use disorder. I would recommend that you actually physically read a copy of that one because it has a lot of pictures, a lot of sketches, a lot of things straight from his journal, and he's a good storyteller. But he also explained to me, I could understand better, why would someone do that? I used to be a NICU nurse. Sterile technique, when you're accessing a vein, is part of my heritage. And he talks about shooting up Jack Daniels when he would run out of heroin. And I'm oh, the nurse in me is that's your thing. You did not wear a mask and use an alcohol swab. Ah, And he really helped me understand better the mindset of what was happening at those moments. Plus, he talks about some of the songs, why he wrote them, when he wrote them, and it's very interesting because he was the songwriter for Motley Crue. If you're going to read one other one, please read Compassionomics. That one's wonderful on Audible. It's very well written, very well said, and it's a study of how being kind and compassionate to the people, patients, clients we serve makes them have better outcomes. Duh, but also this is proving it. So yes, love it. I love when you can back up a plan with some good data, and Compassionomics does that well. So I'll leave those up, but Dana, is there any last words that you would like to add? Any big points about, when you choose care, be caring?
I always say this, because when my whole life, I've always thought nurses are people who want to help people, that are passionate about helping people. And, from my experience, not all of them are. And so I just want to remind everybody to watch what you say. Words hurt people. We had a patient who was standing outside. She went to walk outside of her room after she had her baby, and she overheard the NICU nurses talking about her. And she was in a really, DCS would be coming for her baby soon. She was in a really, it's really hard when people are talking about you like that to not feel like maybe they're right, And so just be careful what you say. Be nice to people. Treat people how you want to be treated. That's all.
Yeah. All right, here are our contacts, and definitely reach out if either of us, I'm looking to see if I got my new email address right. I think I did. If either of us can be of service, again, Dana is still working with Choice and doing an awesome job with them. I'm over at VOA, and my current role is overseeing all behavioral and medical services for Ohio and Indiana. So reach out if we can be of service, and we appreciate you guys listening to us here today.
So I'll just use this one. Okay. We're just going to set up for our panel real quick. So if you are on the panel, come join us. Elizabeth, you're more than welcome to join. Sorry, I'm going to call you out, but yeah. So just give us a few minutes to pull some chairs together, and then we will start the panel. Okay. All right, so this is obviously our panel session. I'm helping facilitate the panel, but I really just want to also have this open for questions that you guys all might have. The first thing that we're going to do is introduce our three additions, amazing additions to this panel. And I just lost all their names. Alicia Wells, Dr. Sarah Turner, and Erica Deeth. So if you guys want to do a quick introduction of yourselves, I'd appreciate it.
Good morning, my name is Alicia Wells. I'm a person with lived experience of over 11 years walking my personal recovery journey. I am a mother. I was dealing with substance abuse during my pregnancy. I have been incarcerated. I left a 4-month-old baby at home when I went to prison. So relating a lot to Dana's situation in giving birth on home detention. Had nurses joking that my baby and I had matching ankle bracelets and took pictures of his and mine. So went through a traumatic situation, but then looking at a prison sentence of over 32 years with no end date in sight. Went back and forth to court and was blessed enough to get a lesser sentence. But in that process, being placed in the We Ones program at Indiana Women's Prison, where I was a nanny, forced to be a nanny as a new mom with postpartum depression for other women's babies. You don't get to choose your job. So the trauma that inflicted. So I come today as a person that owns my own company. My husband, who is a Pearl-Agent, I do infant respite to not involve DCS. We take moms that are needing stabilization care or treatment, and we take their babies. We've also taken puppies, so we can relate to that. My husband never knows what I come home with. And so I'm here to share my story and help advocate for other women like me so they never have to go through what I went through. So it's a pleasure to be here, and thank you.
Hi, I'm Dr. Sarah Turner. I am a local family medicine doctor, and I did a fellowship in high-risk and surgical obstetrics, and most of the women that I worked with in my fellowship were women who had current or history of substance use disorder, so that's where I kind of started that journey and absolutely fell in love with it. So came back to Fort Wayne and have been trying to start a program specializing in this. I call my program the Monarch program. So I provide family medicine care, newborn care, obstetric care, substance care. I'm in the process of becoming boarded in addiction medicine, hopefully in the next couple months. And yeah, I feel like we need more providers doing this. It's a really lonely place with what I do. I don't have partners in this, but definitely a lot of people are starting to catch on and becoming more interested. I work closely with our family medicine residents in town, and so trying to get them interested in it, and slowly are getting there. I see a former resident in the back, which is awesome. So yeah, I love taking care of women and helping them in their journey. So yeah, I'm excited to be here. Thank you.
My name is Erica Deeth. Oh, that's loud. I am a licensed MSW, and I got into the world of social work after having a daughter with special needs, actually. Then got my MSW and started working inpatient in the women and children's area. Absolutely loved working with moms and babies and finding that there were so many areas of social work in women and children's. Then I'm also a mother, have 5 children of my own, and kind of started to focus in on that addiction piece, and so became a maternal recovery specialist, certified peer addictions coach. I do have family members that struggle with substance use, so I'm pretty familiar and just well-versed in that side of things. I didn't initially think that it was an area I would focus on, but I've fallen in love with it, and so I'm just here to help advocate for our moms and help them navigate this journey.
Awesome. Yeah. So if you do not know these 3 wonderful additions, please take the time to get to know them because they're amazing. So the first question that I'm kind of thinking about as we were talking and as we're listening, we talked a lot about barriers to care for women with substance use disorder, but what about barriers to care for providers? So I feel like from Brooke's perspective and from Dr. Turner as well, I mean, what are you guys up against as well, fighting this fight to reach the women and support them?
I think one of my biggest barriers is there's a lot of resources in town. I don't think we have as many resources as maybe Indy does, but I don't know all of them. And I work in a hospital system that we have no social work. And so I often am relying on organizations in town to help connect my patients. So connecting them with Mission Motherhood, Healthier Moms and Babies. I refer them for housing at A Mother's Hope. I have patients that work with Parkview people, so I wish there was just more knowledge in the community. My patients will come in for inpatient starts on Suboxone, and we don't have social work to come and see them, and so we've been struggling a lot with that. I know that we finally have a position posted, but a lot of it's been, well, the nurses can do that. And on top of all the other things our nurses are expected to do, they're not social workers. And so they don't even know all the resources. So I think that's been one of the hardest things, is trying to connect my patients to where they need the housing, the food, all the stuff. So that's been huge.
There are so many the providers that do care about this care about it so deeply, and you can see that in the services they provide. And there's a lot of pioneers in this field who have really stepped up to give exceptional care. So there are really good players doing this. I mean, great providers. Dr. Anthony Sanders in Indianapolis, Dr. Heather Benson, these are absolutely top-notch providers that are mission-driven with the care that they're providing. But we need everybody to get on board. At least if you don't want to do it yourself as a provider, at least don't get in the way of those of us that are trying to. So I'll have, a client who comes to see me, and then For example, they'll go to get their medicine picked up from a pharmacy, and the pharmacist will tell them, you can't take Suboxone in pregnancy, or Subutex in pregnancy. And the client calls me crying, why are you prescribing me a medicine that's gonna hurt my baby? And I'm like, oh man, like that, they
All the
just,
time.
they killed our rapport with that client. Now the client's looking at me like, I don't know, you're getting a commission or something when you write these scripts. And I'm like, no, I'm on your team. And I will have a conversation with that pharmacist when I take my breathing exercises first. So, right? So if you don't want to play, don't get in the way, is what really, I would love to see that. That would be huge. And if you want to play, come on, there's so much room for quality care that's, you know, educated. And there's great support. Like with Champ being there, there's like really no excuse to not reach out for those moments and those references to say like, this is more than I can handle. No, it's not. We literally have a free resource. Go take advantage of it. So there's great opportunity. It's just, you know, let's all get in the game and let's at least support each other.
I would agree with that. I think definitely the lack of social work in or well-paid social workers that want to stay in it long-term in big health systems is a big problem. You know, there is so much money in these health systems, and you have ideas like, what about a behavioral health IOP, for example, for perinatal people? How do we not have that in Indiana? We have, you know, some substance use disorder ones, but we just don't have behavioral health ones, and it's really not that expensive. It doesn't necessarily make money, but it also doesn't cost as much as other services, like, for example, having a baby in the NICU or having a person getting treatment for endocarditis. Like, you know, one person that doesn't have to go through that treatment is going to save so much money. And I totally agree with what Dr. Turner said of there's all these different resources that are out there, that are community-based, that our patients would probably like better than what we could put together in a big healthcare system. But how do we make sure that we connect the person with them when they're with us? Because once they leave, we may not have the right phone number. You know, all the things are going to get in the way. So this morning I was thinking, like, what are some quick ways? Like, really, there should be an app. Like, why are we still giving people a paper? Like, yesterday I gave someone a paper with therapists, and I was like, this is so stupid. They're going to have to call, or they're going to have to, like, type in the website on their phone. It should be really easy, you know, like ordering food with Uber Eats or something. It should be that easy to, like, click onto, not that the person has to come to their house immediately and deliver the treatment, but connecting, I think, should be that easy. I mean, seriously, go to the Black Maternal Health Conference next time it happens, because they have all the apps and all the things and are coming up with all these much nicer production value, and like they're just really willing to use the technology. You know, being there, I was like, why are we not trying to leverage technology? Like, I'm not a technology native, but there are so many people who could like create the things. I'll give you the idea, you do the app, and you can make all the money off of it. Like, I don't want it. But not that I don't want it, but I don't want that to be the thing that stops us. Like, if you want to.
So there is an app.
Okay.
And actually, there's some really good news coming down the pipeline. DMHA just hired Wells of Inspiration to work on a project for vetting out resources in the state of Indiana. And they are looking to create a solid list to incorporate with Atlas, if you're not familiar with Atlas. Atlas is a state program that is, you can get online and see how many beds are available where. So there are things being implemented, but again, it's so early and in the infant stages. And so it's just really exciting. Like you said, there's so many champions, and there are people hearing exactly what you're saying. And so I'm really excited that DMHA has heard that, and it's in the works. So hopefully coming soon to hear.
That's great. Congratulations, by the way, as well. That's awesome. One of the things that we have peer recovery specialists and women with lived experience here as well. And what would you say to someone who is in recovery and looking to help support and kind of like, there is a, need for peer recovery and peer recovery coaches? What would you say to someone who was thinking about it or, wanted to be involved or, what was your why?
Is this working? Okay. We have a lot of patients right now that we found out that the program for peer recovery is waived right now. The fees are waived. So I've had a lot of people ask me, how do I do what you do? But now I'm in a point where I'm going to be able to help these women navigate how to do it on their own. And I think like telling them that I feel like you would, or we feel like as a team, we feel like you would be a good person to do this. It just makes them feel better, and I just remind them how important it is that we need, there's so many jobs right now for peer recovery, and we just need more people to jump in and help out.
I like to remind everybody that their story matters, and everybody's journey is so individualized. And everybody that's looking to get involved in peer recovery, there's space. And like you said, the table is long and it's wide, and we need multiple pathways. We need to know that people have done it different. There's no one way to walk in recovery, because by preaching that, we're actually keeping people stuck in silence. We're keeping them sick and they're dying. And so we need to incorporate more people with different journeys, whatever that looks like. LGBTQ, we want to make sure that we're incorporating moms that have experienced having a baby under substance abuse related issues, or maybe they've had a reoccurrence and they're not sure if DCS is going to be involved. They want other moms to come alongside of them and be able to guide them through mentorship. And so when we had an event in South Bend last night, and it was amazing to have people in the room that were in treatment. We had people in treatment in the room, and we had people in work release in the room, and we said, this is the time. This is your time to come back and give what you've learned and what's working for you. But again, at the same time, being cautious that people are doing it correctly when they're ready, because not everybody's ready right off the bat to share their story, and that can become more damaging if they're not ready. And so the state guidelines, be attending meetings, get involved, show up to events, then begin taking your certification, then get involved with other peer coaches, make sure that you're doing your CEU, and just stay involved, because things change really quickly.
Awesome, thank you. Are there any questions from the audience at all? Now's your chance. I have more questions. Oh, sorry, yeah.
I wish I could say that the answer is yes, but it is not. That would take some additional legislation and policy changes. So at this time, the answer is no. However, when we do get referrals for individuals who qualify for the emergency services, we don't just say, sorry, our program can't help you. We will work very hard to connect them with resources and services so that they can receive help and support. Mm-hmm.
Has anybody in here, show of hands, ever had a experience with Pregnancy Promise, like had a client who utilizes them or use their resources? Yeah. I think this should be like a mandatory referral. I mean, I know it's not like you have to, but it's really a beautiful program. The people that work for them really care and provide compassion, navigation to these clients, and change outcomes. Clients who work with pregnancy, I don't get paid by Pregnancy Promise. Clients who work with Pregnancy Promise have better outcomes. They're more likely to survive, and their babies are more likely to have good outcomes as well. You can't fight that data. I mean, it's a really big deal. So I'm a huge fan of Pregnancy Promise.
Yeah, and a big thing is like that they really understand things that we don't understand. Like I prescribe, for example, an over-the-counter medicine sometimes, but that it could get covered by Medicaid. Like when they couldn't afford to buy it, but Medicaid could cover it. But you have to have Elizabeth and her team helping you, because sometimes you have to prescribe like a specific brand or like a specific way, but you don't have time to figure that out, but they do. So they'll call around and they'll like figure out like what exactly, how you have to do it. And then the other thing is incarcerated. I want Elizabeth to talk about that. They really understand all the rules and regulations of what like someone who is incarcerated like is entitled to. And like if they don't understand it, then they'll figure it out. And then they can talk to other people at Medicaid, you know, that they can just talk to a lot of people very quickly, which the rest of us can't do. So yeah, like I think I keep telling Elizabeth, like how can we figure out how to get every office to have a process, and my office doesn't even have a very good process, or the new office that I'm in. I think the office that I've been in for a long time, yes, we have a good process. Our new office, we need a process. Like what's the process in your office when you find out someone's using opioids, and now hopefully so excited, all substances. What is your office process to make sure every single person gets told about this and gets the opportunity, you know, to be referred? Because at this point, I put in my own referrals online for people, which takes time, and there's one in my mind that I needed to do yesterday, haven't done yet. So, you know, all the offices need processes to make sure they're getting referred in.
Awesome. Oh, yeah.
We have these pocket providers all over the place struggling, trying to do our own thing, right? How do we all, I understand all these organizations and they're great, but how do we get on a local level us in the same place so that we can get to each other? Because I kept hearing this need for this need, and I'm like, I had openings yesterday. Like, how do we get in the same place? Besides using our peers, which are wonderful. Erica's connecting me with people that I've heard by name, you know, and I'm like, oh, that's who she texted. You know, but how do we get in the same place to where we can just message each other?
Yeah. That's a good question. I mean, I think there doesn't to be like I was saying the app, but other ways for each county. You know, I mean, each county probably. Yeah, yeah. Yeah. I mean, PSI directory is one thing, but it's not all inclusive. But if there was like a local version of like a directory like that, and a more active, you know, more active way to do it.
An alliance that
Yeah.
meets quarterly with all our spare time to make this. I mean, honestly, I think it's if someone
But then,
invited me to
yeah.
a thing, I'd be there. I've talked to people about the need for this, and I've had people say, yeah, we're going to set it up, and I think it's just someone just needs to do it.
It's
And
just been so minimal.
There's someone in the
yeah,
There's just not, we're gaining speed now, but
There's someone in the back too who has a question.
yeah, I mean, I think we're just slowly getting more and more champions on board. So there really hasn't been a ton of people, but we are getting more. So yeah, how do we create that?
I think just to chime in too, like about probably a year, we haven't had any meetings, but we were starting a maternal mental health and substance use disorder task force, and it's on me that didn't keep going to a certain aspect because life. But I think it's always been a worthy cause, but I think as the conversation grows, maybe we will look at restarting that task force with a mission. And I think it was just like, hey, let's talk about the resources in the community and, you know, having that mission and actually creating structure for it, for sure.
There's someone back there.
Yeah. Is that like system of care? Yeah. Yeah.
I didn't hear anything.
Oh, it was basically having a branch of like resources, basically how the system of care is structured. So it's a bulletin board. Like I have a client that is in need of X, Y, and Z, and then they're referred to, you know, everybody's like, hey, this organization would be a great resource. Hey, call me, I have it for you. So it's just a very active communication space. Yeah. Come talk to me after.
This is
So grassroots.
Yeah.
I was just going to chime in too about community resources. Two quick resources that we use are findhelp.org. If people are familiar with that, you literally Google findhelp.org, and then you put in your zip code, you put in the resource you're looking for, and you will be directed to websites, referral phone numbers. It's a very user-friendly way to find local resources, and it's findhelp.org. And then while it's not a perfect system, but it is still helpful, I would encourage people to also use Indiana 211 when you're seeking resources in your local communities as well.
On the finding resources in your community, find your local champion. There's many of us out there that are always looking to connect people. That's what we do. Community outreach coordinators. Your local recovery cafe is amazing. Fort Wayne Recovery Cafe is one of the best resources and recovery cafes in our state, I believe. Ryan Marsden is the executive director. His job is to be a hub. His job is to be a hub for local resources from food pantries, substance abuse related issues. Again, that's one of those, or finding other local community champions that you feel comfortable talking to is another good way.
We have that problem. Yeah. 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 Yeah.
Yeah. When
Yeah.
we went to hire, when I had to go in front of the Lords of Hiring at Community Health Network in Indiana and asked to hire a peer recovery coach and explain my why and everything and explain why I had money for it. It was from a grant. I asked immediately for a lenience to our policy about hiring people with certain background situations. And I said, part of this position, and I will say, Dana did not have this problem. Dana was passed the background check without this, but I asked for leniency from the second I asked for the position, for this specific position. And so that was already underway with other peer recovery coaches that were working in that same hospital network. So there are exceptions, because if you're asking people to have lived experience and then you're saying, but you can't have lived experience, what are you talking about? So you're exactly right. You point out a really good loophole. And if you ever need a job, call me, because you would be great. So.
And we've had the same struggle at the health system where I work. We had a peer recovery person that we wanted to hire, and we interviewed him and we really liked him, but we did have to battle for several months after we wanted to make the offer to get through the background check problem. And so we just kept going back to legal until we got through it. Like, we knew who we wanted. The hard part was yet to wait, like, until we got through that, which in his case he was able to, but some people might just not be able to wait while we keep fighting it. Then we had the problem of hiring someone for at IU, same issue, got through it a lot faster. Also a felony situation, so required extra meetings and just advocacy on our part. And you can get through it. They're not the kinds of restrictions where the organization will refuse, but you need the people that are hiring the person to speak up on their behalf. and use their privilege to get through that. But these large organizations do have the bureaucracy problem and just how long things take and mistaken payments and these, not mistaken, like, I wish it was a mistaken payment, like mistaken lack of payment for different things. So I think it would be hard to get the organizations, and it doesn't mean it's not a problem for us to work on just changing them for every single hire, which I think would still be a worthy cause. In the meanwhile, we're doing sort of what Brooke says, is like individually fighting to hire the people we want to hire despite background checks. Like a bigger systematic, like system change, I think would be really important, would be, I think, more timely and probably needs to be, start now and expect that it will take us 5 years or something. 'Cause that's how long it takes for these large hospital systems, and depending on the job and what kind of patient contact people are going to have. So I think the bigger changes, like change the felony system, like that's a bigger thing, is like how felonies get assigned, like syringes, for example, in my opinion, that even shouldn't be a thing. But yeah, so it's like there's different layers. Layer one is just get the people hired now that we need, work so the healthcare systems will let us hire people in a more general way, and then work to change, like government level, what the felonies are assigned for. And I'm not a lawyer, but that's how I would do it.
I'm a 14-time convicted felon. I had to start my own company. I've worked in the treatment industry as well. But have you heard of the Indiana Addictions Issues Coalition? Write that down, we'll talk after. We're trying to advocate at the state level, and we're looking for more peers to come alongside to do. You've hit the nail on the head a couple of times on things that our state is needing, that we're really trying to come alongside and fight for. Brandon George, before he left and went into the private sector, was really big on trying to change this. Unfortunately, politics, advocating, it's an election year, so some things are getting put on the back burner. But as soon as 2025 hits, this is something that we're looking to take to the State House. And we're going to be looking for you to go and get the support from your state representatives to help sign and pass the bill. And we're ready to go to the State House, and we're ready to say why, that these things have to change. Because the problem's not going away, and there's more peers, and the best thing that we can do is work together to bring each other up and keep going back for the next person. So we've got to continue to do it, and if you're interested, that's one of the things that we're going to be taking on in 2025.
Okay, don't want to steal her thunder. That was great. But just to piggyback, I think it just is a testament to another layer of having to find your champion. So now that you're on the other side and you're a peer, you're still having to, overcome those hurdles and find those champions, find those organizations that are willing to fight for you. But it just, again, reminds me of when we were talking about being a peer and all of that. I have this unique position, I think, where I'm a peer and I do community work, but like I'm also layered within a healthcare system. So I do a lot of advocating of that in between, from the providers who are not champions and don't understand and don't get it, and being that in between from the patient, the individual with substance use, and then the physician. In order to get some things to happen or to accommodate these patients, it's a lot of finding the champion. So finding the OB champion, in our healthcare system that wants to help and who's going to listen. Finding our MAT provider who has a heart for these women and who is going to make the exceptions and get it done. It's hard for our non-champions to understand that the policies that were created and the procedures of A, B, C, and D don't fit for our clients. Like, they're not typical or what you would quote normal. It's not a normal pregnancy. We have a lot of other variables going into it. And so that's just another layer that we're able to do as the maternal recovery, the peer supporters, is that in between. And every day we're constantly fighting, I guess I can call them the non-champions, but we're fighting the system that wasn't created for these patients.
And I think too, we still have a problem in just like screening. And technically we're supposed to screen every single patient, every single pregnancy, and it's not supposed to be just a urine drug screen, especially because most offices, I don't know any offices that have a urine drug screen in Fort Wayne that picks up fentanyl, and that's everything. And that's most of what most people are doing. And I think there is a fear in this area for a lot of people because we aren't trained very well unless you seek it out. And I know when I was going into fellowship, I was terrified to work with these women because mostly, I mean, I wasn't terrified of the women. I was terrified of the work because I didn't have any experience in it. How am I going to connect with them? How am I going to have them trust me when I don't know that world at all? And it was a lot easier than I thought it would be, but I think that fear of like, what do I do if they say yes? Where do I send them? Who do I call? And I think that just comes down to like, education within the community, again, about resources and letting people know where the resources are and who to call and what to do when we get positive screens. But I think just screening and identifying these women is still way, 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 way underdone. So.
And like Elizabeth said, people are not presenting because they're afraid. So they're coming much later, which means you're identifying someone much later, and then you have less time to help. This is not the question, but I'll say this because this is something that's been on my mind a lot. I'm glad Brooke was bringing up Fresh Start. Of course, we use them a ton. One issue we've had, and I did bring it up with DCS people at the maternal mortality this week, is even when people are getting in, they're not, like DCS is not letting them take their kids with them. They're saying, we gotta we're gonna hold it, you gotta go prove yourself, and then we'll release the child. But then they're in the whole time, they'll never agree because they'll say, well, you haven't had any clean time outside of, or sober time outside of Fresh Start. Then they get discharged from Fresh Start and they say, well, now you have to do 3 months with no substances. And I'm like, no, I refuse. Like this is ridiculous. And of course the case manager can't do anything about it because they're just following what the person above them says. So that's another thing for us to tackle. I know I've kind of gone a little off the side, but if we're going to screen them and offer them things, and then we have this great program that is being paid for by DCS, and the person's doing all the things they're being supposed to do, but they're not allowed to progress because they're doing the program and they're not out. So it's like, it feels, of course I still recommend Fresh Start and try to get them to go, but it hurts me to think I am actually delaying them being reunified, just based on the current rules and how people are applying them. It's happened to us a couple times now.
Yeah. And
That's not a Fresh Start problem, but it's something Fresh Start, I think, can advocate for.
Fresh Start can fix it. I mean, I love a problem. Let's figure it out. There's always a solution, right? And so a problem is simply a challenge to find a solution. And that DCS is an interesting entity because there's a lot of people who really care in DCS, and I never want to put that as like, oh, DCS. Like DCS I tell my clients, DCS can be a huge resource for you. And then I, in my heart, pray real hard they get a caseworker who cares about them. And then sometimes they do, and if they don't, then I would never yell at someone at Starbucks for making my drink wrong. But I will go postal if my client is going to be harmed by what's about to happen. And I will pull a full care and fit on DCS if I have to protect the client. And I've rarely had to do that because usually you can just have a conversation and figure out what makes sense. Somebody coming to Fresh Start, where Fresh Start can keep baby safe during this process and not allowing baby to go with them to Fresh Start is a fiercely punitive system that if you encounter again, please reach out to me. I'd love to get involved
And I
directly.
think it's really so county by county and person by person, like you said, and that's kind of like what upsets me about, in a way, even having to have champions. I want to be a champion, I am a champion, but the fact that there's so much money poured into these healthcare systems and grants and all these things, and we're still finding a champion, finding a workaround, it's just such a waste of time and energy. Very upsetting that we still are doing that, and that you can't predict, right? If you have trauma, if you have insecure attachment, and then you're coming to me and you're saying, what's gonna happen to me when I go through this DCS process? And I have to be like, I don't know. Here's what I'm gonna do to help you, but it just depends so much on who you get as your manager, what county you're in. I mean, I'm in a regional academic medical center. I'm taking care of people from counties that are not the county I'm in. So,
You see great variation amongst counties.
100%.
yeah.
Variation.
And it's terrifying. I feel like patients come in and I wish that there was, I know it's not black and white, every patient is different, but I can't even give you a scope of the rules.
Yeah.
You know, someone comes in and has a baby and has absolutely no prenatal care, tests positive for cocaine and lives under a bridge, and she got discharged home with her baby.
Yes.
And home as in a tent under a bridge. And then I had a patient who got herself into recovery at 8 weeks and was absolutely sober the entire rest of her pregnancy and had her baby removed. And I'm like, how do I counsel patients on what to do? And I had a mom, that mom who lost her kid at 8 weeks and 2 years later had maintained recovery and still didn't have her kid back. And she goes, what's the point? What is the point of staying in recovery when they get removed anyway? And I'm with you, you know? The lack of sort of guidance on our side on how to, you know, talk to them about what's going to happen, and then they have that fear, and it's the caseworker you get, the judge you get, you know, and I've had caseworkers and judges tell patients, oh, you're on Suboxone, that is child abuse. And the fact that people still think that is just bananas to me, and we have made amazing strides in this community since I moved here 7 years ago. Like, I just feel like things have definitely, not because of me, but just I feel like the education in the community has definitely moved. But the fact that still we will go, we had a NAS task force, we went and did education with DCS. And at the end of the education of, no, this is a medical problem, we are treating a medical problem with medicines. Nope, it's still child abuse.
Dr. Arnaudo said a great thing, that the legal, I think it was you who said that the legal system cannot dictate medical care. Was he?
Right.
Yeah. And
Yeah.
when the legal system dictates medical care, you don't end up with the best outcomes. I wouldn't tell my
I mean,
clients
it's
what to do
illegal
legally.
also, and there could be a lawsuit about that because that's illegal.
Right.
Which a good friend of mine who's a lawyer has like kind of thought about doing a lawsuit on it because it is illegal for them to prescribe medical care, although they do it in Indiana in a lot of different areas. But I do want, like, I appreciate what you're saying, Brooke. Like, it's never the individuals. Like, it's not the individuals within DCS that are the
People are
problem.
fundamentally good.
Yeah, and before I did perinatal work, I had a lot of DCS workers as my patients who, like, got into it to want to, like, take care of kids and protect kids. And then they got put through this huge caseloads and a lot of weird, like, little rules and things, and the fear that you are going to lose a baby if you do something wrong. And then in maternal mortality review committee, we see lots of people who are adults now who should have been removed, or at least should have been put with a different family member, or whose parents should have been helped more, and they weren't, and now they end up dead as an adult from an overdose because the whole thing, you know, didn't work. So it's really, really not an individual DCS person. Everyone is like, again, I still believe in unconditional positive regard in general, so I believe that with the DCS workers too. But the problem is they have a lot of power, and unfortunately, the way that gets applied is not equitable, it's not just, and we as providers can't, like Sarah said, like, we can't advise the people what's gonna happen. So how, right, like, you never know what's gonna happen in someone's life, but in my system, I know you come, you do this, I give you the medicine, but I can't tell them, like, and you'll get to keep your baby, like.
And I've seen Dana have these conversations with clients, and she can just be so gracious with them about, like, this is what happened with me. I don't know what's going to happen with you because we can't predict totally what DCS is going to do. Let's minimize the risks of them getting involved, and I'm going to support you with this if it happens. If worst case happens, I'm shoulder to shoulder with you. And if best case happens, we're setting you up as, like, you've got to stop utilizing marijuana because that's going to be an automatic DCS referral at delivery. Whereas if you test negative at delivery and your baby tests negative, then they won't have to. Do you want DCS in your house over marijuana when you've done so much? Like, those are conversations that Dana has in a beautiful way that allows these clients to be ready for as prepared as possible.
We've been struggling with an additional layer at our hospital. So we don't have a social worker. We send out the cords. The cords come back usually after
Right.
the
Client's
patient's been
already home.
discharged.
Yeah.
So who gets the result? Me. So who has to call DCS? Me.
No.
Yeah. And I've been fighting that because I'm like, I'm not going to be the person who's trying to protect my patient and also be the person who has to report.
No.
And I will openly admit there's a couple of cases where I felt like there was more harm in reporting, so I didn't.
Man, just play the card. My time is, you're paying me too much to do this. You should pay someone else to do
Right?
this, right? I don't know. That's terrible,
But
stress.
it puts me in an awful position.
Yeah.
I'm the advocate. I'm not supposed to be calling.
That is like another, I mean, I do really believe in voting and going to the State House. Obviously, it's a tricky state to vote in, but you have to try and vote and, and try to get some of these laws changed. I don't know. I think it's just really, I'm part of like a physician sort of activist group that operates in the shadows, to try to change some legislation. And you just gotta figure it out. Who are the lobbyists and what are they doing? And get your own lobbyists and do your own testimonies that are not involving with your healthcare system. There are some low-hanging fruits. I mean, there are some legislations you can change that are flying under the radar but are bad for people. And then there's the bigger ones. But you have to get in the State House, like you were saying, because the laws are really horrible. Like the law that requires you to turn everybody in who has a positive cord, that doesn't denote abuse in any way. That's a waste. To me, that's why kids are getting abused, because we're wasting time tracking down people that have positive cords that are doing completely fine now.
Well,
It's the
especially
most-
when the cord's positive for Matt.
Yeah,
Yeah.
it's so stupid.
Well,
Such a
that's
waste
what's
of
burning
time.
out DCS, which leads to the turnover.
And it's not what's killing babies. Like if you go to femur, that's not why babies are dying. So that's another thing that's very upsetting.
Very good. Well, just kind of to tie it all back as well, I mean, it's something that keeps going on in my mind is how maternal substance use is the leading cause of death for women, or maternal death in the state, and how there's 35 of us here who had come out today. There's 20 people online who've been tuning in. And this conversation has got to be bigger with more people involved. And I hope that everybody who's come today is doing such amazing work, but continues this conversation as we go into, next year. And we just kind of keep building on this because, it's such an amazing, it's such a worthy cause. Everyone here is so passionate about it in their own right and what they're doing. And up against a system that is clearly broken for women, especially when they need it most. So I just want to thank you guys for joining the panel. Obviously, we'll be hanging around for a little bit. I think you guys would probably talk for hours, is what it seems like. But yeah, you guys will be hanging around for a little bit. We're going to wrap up. We're going to have Brooke do a call to action, and then we're also going to share just a little bit about Mission Motherhood's new program, The Villages. So thank you guys all for being a part of this.
Thank you, Jennifer, for organizing it and inviting us. You're the doctor here. How are we gonna?
I know. Sorry.
All right.
Dramatic end for you, Jennifer.
Let us know when you want to hop up.
Hello? Ooh, okay. All right, so as a good steward of time, I love when a meeting ends on time. I actually get real twitchy when they don't. I'm like, oh, we got to end. So I really want to bring a call to action. And the one that's really occurred to me today with all the things that we've been talking about is what can you do right now? I love when you leave a group like this. There's so many great ideas. We need to do things with legislation. We need to improve access to providers who want to help. We need to improve how we navigate and work as teams. Yes, these are all great long-term goals. What do you do today? And I truly believe that the cultivation of optimism is the greatest thing that we can bring to this care. That's the thing that I really would love to see more of in this field, is people maintaining their own optimism so that they can bring kindness to the people they're caring for. It makes a huge difference. You say, like, well, I don't have the resources I need. But if you have a good attitude, even when you're looking at somebody and saying, I don't have a resource for what we can do with Bullet today, but we're going to figure it out. Let's find a solution. That attitude of we have to find a solution, I'm optimistic enough to think it exists. Optimism is so rare right now in the world that we live in. There's so much that would encourage us to be cynical, but it's so important that we absolutely, if you're not optimistic, you find a way to find it. You find a way to get to it. And there's so many resources to do that, but it's very individualized. And it's not, for some, it's not just about self-care. It's about truly surrounding yourself with others that lift you as well. There was so much happening here that was really cool to see how people were interacting with each other just in this small group of people who are ready to do this work. If you want to be a beacon of light, find another beacon of light. Work together. Get those resources. Get out there. The thing that I heard said was how there should be an app that helps with this, right? There should be ways to utilize our resources better. One of the things that we always joked about in Choice was that if you print out a sheet of resources and you hand it to someone, and that's all you did, you didn't do anything. You didn't help. Don't feel good about that. That wasn't a good move. Because you didn't establish, like, do you have a phone to call these resources? Do you have a way to get to these resources? Do you want these resources? We need to think about the clients we care for as people, and making our optimism and our compassion as full as possible is a big part of how we can bring what we have to them. I loved, and I wrote it down so that I would remember it because my brain hadn't held it yet, but that unconditional positive regard, what Dr. Arnata said, that, like, I feel like I want a tattoo of that. That feels like exactly what I'm talking about. The cultivation of our optimism, the cultivation of our belief that the people we are working with are doing what they can, and we're going to work within the confines of what they can do. It is amazing how much growth people make when others believe in them. As the provider, I've had clients who have been my patient for several years. I've seen how well they're doing in their recovery, and I look at them and say, I think you would make a really good peer recovery coach. And it blew my mind how many of them, like, cry when I just say something like, I see you as a person, I believe in you in a person, and I think you could be part of this fight. It's like they were just waiting for someone to ask them, because so many of them have never been told. I'll tell them, well, you're a really good mom. When I see them do something that's fantastic, I tell them that they did it. And I had one client say to me, no, I always congratulate my clients when they come in with a new pregnancy. Like, somebody comes in, they're brand new to recovery, they're pregnant, I say congratulations. Nobody has congratulated me on this pregnancy yet. Okay, well, here we are. Let's go forward from this moment. Today, I'm glad you're here, and let's talk what we're going to do. And so lending that light to other people is what I'm going for with that. That reaching out to the client and saying, I think you'd be a good peer recovery coach. I have a reason why. Giving those compliments, being part of bringing people into this work with us if you are already a beacon of light. And if you want to be a beacon of light, there are so many people that want to play. There's so many ways to get involved in this work in a way that really changes the outcomes for the people that you are caring for. I loved also that Dr. Arnata brought up the concept of harm reduction. That goes along with what I was talking about with the concept of progress, not perfection. So harm reduction can save a life that may lead to what you consider to be recovery, but you need to be open-minded about what harm reduction does at that moment is literally reduces the harm of what's happening. That is a step forward. Sometimes harm reduction is as far, like getting people safe supplies for use is as far as that moment in time they're ready to go. That's a start. There's so many steps forward to get to the work that Dana has done. And so starting that journey for people, being that first person to be nice to them. I had one client tell me once that she went to the ER after an overdose, and she said, I did not care if I lived or died. And in the ER, there was this nurse that I wouldn't open my eyes because I didn't want to look at these people. And this one nurse kept just being nice to me. She kept saying, are you okay in here? You look like you're cold. I brought you another warm blanket. And she said, that lady was so nice to me. Will you call her and tell her how nice she was to me? And I was like, oh man, the chance of me tracking down who your ER nurse was 6 months ago who was nice to you is almost zero, but try. And I got in her chart, and the girl's name was in the chart. She had signed off like a rounding note, and I got to send her the email that said, hey, this client wants me to tell you thank you. Your warm blankets and your kind voice are the reason she didn't leave the ER that night. And that's why she ended up in recovery, and now she's been stable in recovery. She wanted me to tell you. And the ER nurse is like, I've never heard how any of my how patients ever do. It's not something in ER you get to know usually. She's like, oh, that was big. So, beacon of light, you don't always, at the moment that you were the thing that made a difference for them, but that's not why you're being the beacon of light, right? Because it's not about you, it's about the impact it has on the clients we serve. All right, and one last comment I want to bring up here, and then I'll get passed over. I really want you to be thinking about this concept as you walk away today about fighting in the lifeboat. There's something I see in the recovery community sometimes. We're all so passionate about the work that we do, and you'll see all these great beacons of life, and you're like, oh my gosh, everybody's so passionate. This is so great. I want to be part of this fight. And then you'll see them infighting amongst themselves. You can't treat people with substance use disorder if you don't have lived experience of substance use. You can't, have any opinion about medications unless you're a nurse practitioner or a doctor. We need to be all in this together. So it's beautiful when you see a team that is made up of multidisciplinaries working towards the same goals. Peers, working with doctors, working with social workers, working with therapists. That's where you see clients have the best outcomes, is when there's multiple specialties working together. When there's only one kind of specialty, you've really narrowed the field on what can be done. So as you're leaving today and you're going forth and you seek ways to become involved, look for opportunities where you are working in a group of multiple different specialties. Shouldn't only be one kind of specialty. It should be all sorts of different kinds. Because we had, stems from a time when one of our nurses in Troy got in a fight with the recovery unit, a verbal altercation. And that recovery unit said, hey, we're all in this together. And literally said to her, there's no hope. Let's all get along and figure this out. And the nurse was like, oh, man, okay, you're right. I was getting too passionate. I need to focus. We're all in this together. Recovery, we need to work with each other to get the help of these clients, and that's us getting along as a team too. So definitely no fighting in the lifeboat. Keep that beacon of light, you being an optimistic beacon of light as the care that you give. And if you need help being one, look for another one. Be part of what they have going. I know that today, last thing that's going to be happening here is talking about the villages that's going on with Mission Motherhood. I'm looking at time and want to be a good steward, so we will go ahead and let them come up and get you started with that discussion. Lots of good things coming, and it's exciting to see all the good in this room today. That's always a good filler, being around people who are also part of the solutions. Thank you.
All right, so really quick, before I get into it, we wouldn't be here without our sponsors. So I'm beyond grateful for the collaboration that we have, the Allen County Drug and Alcohol Consortium, their opportunity to even make this an opportunity. So I'm just grateful for them. Indiana Department of Health, through the Allen County Drug and Alcohol Consortium, is the reason that Mission Motherhood has been able to grow over the past year and expand and grow in awareness, and I am forever grateful for that opportunity. I'm not going to get emotional, but I very much appreciate it. And obviously, the University of St. Francis, they generously give us this space. The wonderful AV team, even though we've had some hiccups today, but we're all in it together, right? So it's so much appreciated, everything that you do. And just giving us this space and opportunity to come together, just very grateful for that. So thank you for all of our sponsors today. So what is the Villages? We talked a lot about peer support, community support. The Villages came out of this need for it. There's going to be a video, so don't worry. The Villages is basically a peer support program that provides 2 to 3 peer coaches to a mom in recovery, whether that's substance use disorder or maternal mental health condition, so that she's supported with wraparound care for and everything that she's doing and in her journey wherever she's going. That means being able to provide resources from the state level, from the local level, making sure that she is surrounded and cared for. So we have a little promo video on our website. You can find some more information if you have a referral of a mom who needs services, if you yourself would like to be a volunteer and begin the journey of a peer recovery coach with added maternal mental health specialty to that. We would be more than happy to talk to you more about that. And let's see, get this going. Hopefully it works for you, for us.
Having a village.
It is not showing. It's on here, but not up there. Oh, maybe I need to close something. Sorry, guys. I'm going to just talk to myself. It's not like in my video. Everybody thank Evan for coming down today. Yay, all right. Here we go. And you might see some familiar faces as well.
Having a village is everything. Having people that you can call when things are hard, having somebody that's going to come and sit with you and not exactly tell you what to do, but sit with you in it and recognize what's happening. The village is so important.
What it means to me is amazing. I can't even put it into really words. I'm thankful that I've had the support that I have, and what it means to me is a better way of living, a better way of life.
Having a village to me is that I have a lot of people in my community that can help me take care of people and help me recover them properly, rather than just doing the small bit that I do. As a mom, having a village is having a bunch of different people, resources, community associations that can help with the different problems that I go through as a mom.
If I didn't have people that loved and supported me around me, I would never have half of what I have today, you know? It seemed like everybody pitching in to make sure that I have an okay life. And I don't think I would have been able to do it without my village. I think it's important for all mothers to understand that we are all in this together. Every struggle that you've faced as a mother, you can feel comfort in knowing that we're all going through similar things. And if we can come together as a village and support each other, then we can all succeed and every child can be happy.
All right, guys, that's it. For more information, just let me know. This has been super, such an awesome day. This is such a passionate piece of programming that we do, and thank you all for your time, your experience, and what we're going to do to go change the conversation. Thank you very much.